Okay, so hopefully you graded Chapter 4 using the answer key on page 201, and I'm going to go ahead and get your scores. Delilah? Thank you. Jenny? Isaac? Thank you. Fermana? Fermana, do you have Chapter 1?
Yes.
Thank you. Victoria? Kaylee? Thank you. Diana? Okay, that's fine. Naomi? Andrea? Sarah? Thank you. Daisy? Do you have Chapter 3 for me, Daisy? Thank you. Teresa? And do you have Chapter 3 for me? Thank you. Christian? Do you have Chapters 2 and 3 for me? Thank you. Faith? Do you have Chapters 2 and 3 for me? Thank you. All right, anybody have any questions? No questions? We're good? Ready for that final? No. Let's review. Before we get to the review, just remember that changes of aging, caring for patients with specialized needs like aging is going to be an entire category on the state exam. So everything from Chapter 4, there are 7 questions in this category. So you're going to get 7 questions on this content. But everything that you need to know is on that sheet. Okay? Good. How do we know what to do with each patient? Care plan. We follow the care plan, the whole care plan, and nothing but the care plan. Anybody catch the game show yesterday? Okay. Okay. Yep, you just put the number in the comment and hit send, and that's how you participate. If you caught my game show yesterday, I had 2 questions specifically from here. The care plan, the whole care plan, and nothing but the care plan. And a lot of people kind of put things into the question that actually weren't there, and that led them to the wrong answer. Okay, so if you didn't get a chance to watch that, go back and watch the replay. It's always up there. I have 3 years of game show replays up there for you. So if you just go through all of them, you'll get, I don't know, something like 700 questions or something. It's a crazy number. It's a lot of questions that you have access to. While we're following this care plan, what should we be making? Observations, that's right. And who needs to know about those observations? The nurse. So we're going to be working closely with the nurse to make sure that they know everything that we know, okay? Every skill starts with an opening. Every opening starts with a knock. Yeah, patient privacy is important. Once we enter the room, we want to greet the resident and address them how? By name. What do they need to know about us? Our name and title. And then we have to tell them what we're there to do, right? What is our skill? Why are we there? All of this information is necessary to get one thing from them. What do we need? Consent, that's right. Once we have their consent, then we can close the curtain. Is that curtain clean? What do you want to do after you touch curtain? Go wash your hands. And once we have clean hands, then we can go over and get our clean supplies. Everybody good with that? Okay. Every single skill that we are going to do, well, let me real quick. Remember that don't touch the patient until your hands are clean. That's our cardinal rule there. But every single skill that we are going to do on a patient requires us to think about gloves. It doesn't require us to wear them, but it does require us to think if we need them. So glove evaluation is a part of every single skill we do. Wearing gloves is not. So we have to know when gloves should be worn. if we're going to touch, anybody know the first one? Okay, personal skin is one, body fluids is one, and non-intact skin. So anything that has any type of an opening. So a wound, a rash, a sore, or even an incision, anywhere where the skin, is not completely intact would be a skin opening. If we are going to touch any of those things, or if we might touch any of those things, if there's an unknown, then we need to wear gloves. Okay, good, good. If we decide that we're going to wear gloves, what is the first thing those gloves should touch? The patient. Keep your gloves clean for the patient. Now, once you've touched the patient, those gloves are no longer clean, so pay attention to what you're touching in the environment. Try to minimize your cross-contamination, okay? And then if we have worn gloves, how we remove them is a graded checkpoint. So we need to know the right way to remove our gloves. Dirty glove can touch dirty glove, that's fine. Dirty glove cannot touch your skin. Okay? Good? Good. All right. If you're going to use supplies, you need a clean place to put them. And the table is not considered clean. So we're going to use a barrier. This gives us a clean place to put our clean supplies. The barrier is always about clean. Okay, good. All right, remember that when we're working with supplies, you have to have clean hands to get your supplies, so we do this after hand washing. Again, all about clean. So we do our opening, we wash our hands, we go get the barrier, we put it on the table, we get our supplies. Good, get that barrier first. When you're getting your supplies, it cannot touch your uniform. Your uniform is not clean. Your hands are, you just wash them, but your uniform is not clean. Good. So the way this works is you do your opening, you wash your hands, you go get the barrier, you put the barrier on the table, you go get your clean supplies and put those on the barrier. Good. Easy, right? Easy. You can touch the table. You'll notice if you pay really close attention in the videos, you'll notice that I wrap the barrier around the table when I move it. So I use that barrier between my hands and the table. That's not a graded checkpoint. They're not going to get that nitpicky. But my thought process is always on the patient I'm about to work on. And if I were the patient, how would I want this done? I know that in that setting, there's a lot of pathogens. And I know that I don't really want any of them on me. So I always do my skills with that in mind. Remember that the test is entry-level skills performance, not mastery. You're not showing them that you understand every part of being a CNA, you've got it down, you're an absolute master at this. That's not what this test is. This test is kindergarten. Just, do you know enough to keep our patients safe while you're out there learning? That's really what the test is about. So they're not going to grade you that harshly on whether you touch the table with your hands. That's not a thing that they care about. It's a thing I care about, but it's not a thing they do. Okay. Does that make sense? So if you watch my videos closely, you'll actually see that everything I do conforms to these rules. Everything I do conforms to one of these rules. But I also will do little things that you probably don't pick up on initially, like touching the table with the barrier between my hand and the table. Just going one step further. A lot of students don't use barriers. When they get out there in the clinical setting, they just don't use barriers. And remember, the barrier is all about clean. It's keeping our clean supplies clean, and that's kind of important. But what's even more important is it gives you a place to put dirty things once you're done using them. You don't want to be doing peri-care, which is very personal care. You don't want to be doing peri-care and put that washcloth directly on the table where your patient's going to eat. right? So that barrier is there for clean stuff, but it's also there for dirty stuff as well, because remember, nothing goes on the floor. Does that make sense? We're going to see that a little bit more as we go. All right. We also learned about a privacy blanket. Privacy blankets aren't just for privacy. They're there also to keep our patient warm because the facility is cold and you're not going to feel that cold because you're very active and you're fully dressed. Remember, your patient is not as dressed as you are, and they're, for the most part, pretty inactive. So the temperature is always going to feel colder to them than it does to you. And if we don't kind of recognize that, then we're probably going to make our patient uncomfortable. So it's not just for privacy, it's also for warmth. We're going to use a privacy blanket anytime the patient's uncovered or undressed. Nobody's going to tell you to use a privacy blanket. It's not on the care plan. The nurse isn't going to tell you. This is just something you need to know. If the patient is uncovered or undressed, they're probably uncomfortable. And our job is to make them comfortable. So we're just going to use a privacy blanket. We're not going to wait to be told to use one. Does that make sense? Remember, that's all of our principles. Everything that we're going over now are not things that are going to be on the care plan. Care plan is not going to tell you to get consent. Care plan is not going to tell you to close the privacy curtain. Care plan is not going to tell you when to wash your hands. These aren't things that are covered by the care plan. These are things we just have to know. And that's why you're in class. Okay? Good?
Question on the care plan. Does it ever tell you that the patient has a rash or has a cut, or so that you prepare yourself when to put the gloves on?
Not usually. Not usually. So remember I said that we're going to wear gloves if there is a body opening, body fluids, or non-intact skin, right? Personal skin, non-intact skin. Well, the care plan isn't going to tell us the patient has shingles, a rash. It's not going to say that. We have to know that we have to provide this layer of additional barrier anytime we might touch those areas. So if you're working on very exposed areas, you're doing hand and nail care, you can see the hands before you ever start, okay? If you're doing range of motion, you can see the arm before you start. If you are trying to think of all the things, if you're taking a pulse, you can see the arm before you start. So those are visible skills. Now, if you are going to change occupied bed, this is something that we learned last class. If you're going to change that occupied bed, you have to put your hands under the patient. Now, if that patient is fully clothed and holding onto all of their own body fluids, there's no real risk there. But what if your patient is this lady? She's in a hospital gown. And I really don't know yet if she's got the ability to get up. So I don't know if there's something underneath her, right? I don't know if she's got undergarments on. There's an unknown there. So I would wear gloves because there's a maybe. Okay, does that make sense? So if the answer to any of our questions is yes, we're wearing gloves. If the answer to any of our questions is maybe, we're wearing gloves. If the answer to our questions is no, we don't need them.
If your patient, you walk into the room and the patient asks you, although they don't have anything on them, and they ask you to wear gloves constantly when you're with them. In this case, how do you approach this?
That's fine. If that's what helps the patient feel more comfortable, I'm for that. That's fine. That is fine. But the same rules apply. We've got to, the first thing those gloves should touch is the patient. We have to remove them correctly and be careful about what you're touching in the environment. But yes, there are situations where your patient may feel more confident or comfortable that you are wearing gloves because they understand they're in a very pathogen-rich environment and they don't trust your hand washing. And that's really kind of what it boils down to. They've had a bad experience. They don't trust your hand washing. And that's okay. I'm okay with that. But I definitely am going to make sure that I am dotting all my I's and crossing all my T's here and making sure that I don't bring this patient anything they don't already have. Because if they're thinking about infection control, there's a reason they're thinking about infection control. Good? Makes sense? Makes sense? Sometimes patients are a whole lot more knowledgeable than you think they are. And so my mom had an allergic reaction, and it was absolutely, they almost intubated her. It was so bad. They had her in the ICU, and I went up. When I go in the room, she said, you know, she whispers to me, the person in the next unit, because it's ICU, right? Person in the next cube has C. diff. I'm like, how do you know that? She said, because they were just talking about it in the hallway. Now, first of all, that's a huge HIPAA violation, right? My mom should not have had that information. That's a HIPAA violation. Those nurses should have known better. HIPAA violations happen without you even, they happen, but that's a problem. But number two, I know that C. diff is right next door. Do I trust these people with my mom's life? Absolutely not. Not when they're walking in the room and using hand sanitizer. Does hand sanitizer work on C. diff? No. So I asked, can you please wash your hands? And I got all kinds of attitude. All kinds of attitude. So after that, instead of fighting with the nurses to get them to wash their hands, do you know what I asked them to do? Yeah. And the pushback I got was, I just washed my hands. No, you use hand sanitizer. And I know what's in the cubicle next door, and I'm not putting my mother at risk. So put on a pair of gloves, please. I'm not playing here. I'm not playing, because that is my mom. That's not just a patient. That is my mom. So if somebody asks me to wear gloves, there's a piece of the puzzle that I have missed. And I'm going to really kind of take a look at my own practice. What did I miss here? What does this patient know that I don't? Does that make sense? Okay. Yeah. Your patients and the patients' families are not going to play. And they shouldn't. They shouldn't. We need them to keep us on our A game, because when you punch that time clock every single day, and it's the same stuff every single day, we all fall into monotony, and that breeds bad habits. So we need them to keep us straight. If you have a patient or a family member that asks you, hey, did you wash your hands? You should be thankful that they are keeping you on your A game. Oh, I don't know. I'm not sure. I think I did, but let me wash them again just in case. I'm not going to get an attitude with them. This is their body. These are their consequences. I'm not going to say, well, I'm a nurse. Don't you question me. What does that prove? What does that accomplish? Doesn't accomplish anything. I'm going to say, I think I did, but let me do it again just to make sure, so we're both on the same page here. Thank you. Because sometimes I might forget. I might have a whole lot going on in here. That's okay. Make sense? Good? When I say it's all about the patient, what I mean is it's all about the patient. Not us, not our knowledge, not our ego, not our processes. It's all about that patient. Now, I get it. There are patients out there that are just out to make your life difficult. They exist. They exist at Walmart. They exist on the highway. They exist everywhere. And I'm not naive enough to think that they don't exist in a clinical setting. But those Walmart employees have to deal with it professionally. Those servers have to deal with it professionally. Why do we think we're exempt from that? In healthcare, we kind of forget that. So even though they're a pain in your tuchus, and I know they can be, we're still going to do what we need to do to be professional with them, because that's what we're being paid for. We're being paid to be professional. Good? Make sense? Okay. So when we're using a privacy blanket, so anytime the patient is uncovered or undressed, we're going to put it on over the sheet and pull that sheet down under the blanket so the patient is never completely exposed. When we put that blanket on, we're not going to snap it or shake it. Just lay it out over the patient. Now, if this is a skill where we decided to use gloves for whatever reason, if we have gloves on, we don't want to pull that sheet up with our gloves on, because if you wore gloves, that means you touched body fluids, or you touched personal skin, or you touched non-intact skin. Do you want to get that stuff on that sheet that's going to go right up next to their face? So if we wore gloves and used a privacy blanket, if both of those things are true, take your gloves off before you pull the sheet up, before you take that blanket away and pull the sheet up. Good? Good? All right. That sheet's going to go right next to their face, and that's just gross. All right. Linen rules. Linens cannot touch your uniform. We've heard this before with barrier rules. You have to have clean hands to get your linens. We heard this with barrier rules. Don't snap or shake the linens. We heard this with privacy blanket. Nothing new here. This next one, well, I skipped it here. I got to change that. Remember, clean rolls toward me, dirty rolls away, and nothing goes on the floor. And then anything you take but don't use has to be discarded. Good? Don't reuse it. Don't leave it in the room for later. Don't put it back into clean storage. We're going to discard it. So we really do need to learn our supplies, so we're not just taking big stacks of stuff that we don't really need. Okay? Scoot and roll. Your patient has to be in the middle of the bed at all times, and we don't have side rails in all settings to keep them safe. What's interesting about side rails is that in a lot of settings, they're not even on the bed. They're not even on the bed. They've taken them off the bed. And if we get an order for side rails, we have to call maintenance and ask them to come up and put side rails on the bed for us. They're not even there for us to use. Do you know why that might be? Why would they take the side rails off the bed? Okay. All right. Yeah, it makes them feel confined. It can limit their movement. Say it loud. Because people were abusing the power. Yep. That is why you do not have side rails on the bed. We told people, don't use side rails unless you have a doctor's order. But CNAs would put them up because I don't want that patient out of bed. If that patient falls, it's on me. And that was the mindset. I don't want to be in trouble for them falling, so I'm going to put the side rails up to keep them from falling. Well, congratulations, you killed them instead. Which one is better? The problem is when we start making decisions that aren't on the care plan, we're putting our patient in danger that we don't even realize because we don't have enough information to work with. So we follow the care plan, the whole care plan, and nothing but the care plan. And this is how we keep ourselves and our practice, but also our patients safe. If you have a concern about that patient, instead of putting side rails up, what should you do with that concern? Tell the nurse. Absolutely. Absolutely. Good? Now, if you're working with really old CNAs and nurses, people that have been in the industry for 30 years, we used to be trained that every time you walked away from a bed, you put the side rails up. That's how we were trained back in the 80s and 90s. That was a thing until we realized, hey, our patients are getting hurt. Something's wrong here. And they re-evaluated, and now we have these rules. That's why I have to go over this quite a bit, because I don't know how many of you were taught to use side rails. So I have to break that down. Okay. All right, so in order to keep a patient in the middle of the bed, if we have to turn them, we're going to scoot them toward us first and then turn them away from us, which puts them right in the middle of the bed after the turn, which is exactly where we want them to be. Okay. There we go. Okay, we always turn a patient away from us. We remain behind, they're behind. Never turn a patient toward you. You don't want them to be eye level with your crotch. Just makes sense. And the patient must always be in the middle of the bed. This is a serious testing checkpoint. Serious. So one of the skills that we're going to learn Monday, I think it is. Is it Monday? Might be today. Today. Actually, the first skill we're learning today is side lying position, which means we're intentionally going to turn that patient on their side and we're going to use some pillows to keep them there, okay? That is a skill that we're going to learn. Super easy skill, it's a great skill to be a patient for. You'll never be this comfortable again. It is a great skill to be a patient for. The problem is that you will pay attention to the steps, not the patient. The evaluator is looking at that patient after you get them all situated to see, are they in the safe zone, in the middle of the bed. It doesn't matter how pretty you did the skill if the patient is not in the middle of the bed. Make sense? So remember that this is our really important checkpoint. We learned washing rules. So everything we wash, we rinse, everything we rinse, we dry. So we need some rinsing water to work with. So we don't put soap in our basins. Basins are no soap zones. Soap goes on the washcloth. You're going to wring the washcloth out really, really well. No drippy wet washcloths. Put the soap on the washcloth and then use that washcloth where we need it. Now we still have clean water for rinsing. Okay. That faucet is not clean. Your hands are. So we need a paper towel between our hands and the faucet to get water. Remember, we've done our opening. Good morning, Ms. Jones. My name is Patty. I'm your CNA today. I'm here to whatever. Is that okay? I'm going to close your curtain, wash my hands, get my supplies. So I've got clean hands here. If I touch that faucet to get water, my hands are no longer clean. So paper towel to get the water. We're going to check it with the inside of our wrist. It should feel warm, not hot, not cold, just warm. And we're going to ask our patient to check it too. Now, if they say the water is too cold, what should we do? Warm it up. If they say that water is way too hot, what should we do? Cool it down. Should we tell them, I checked it, it's fine? No. All right. We're going to cover this next step later. Whatever we wash, we rinse. Whatever we rinse, we dry. All three steps. I know this is really simplistic. This will save you because you will forget a step. If that water gets cold or soapy, if we're taking a long time to do this skill, and that water cools down, don't wash your patient with cold water. That's just mean. Let dry surfaces remain dry. So we're going to cover our table with a barrier. If the patient is in bed, we're going to cover the bed with a towel. We're going to make sure that whatever surfaces we're working on stay dry throughout the process. And if we're going to put lotion on, we warm it up in our hands first, put it on, and then wipe off our excess. Good? So those are washing rules, and in order to wash something, we need a basin to hold that water. So now we're going to get to basin cleaning. For the test, basin cleaning couldn't be easier. You rinse it, you dry it, you store it. That's it. That's all they're grading you on. Rinse it, dry it, put it away. But there's a special process I want you to learn, because if we have to disinfect, when we do it is going to matter. And how we do it is going to matter. So we're going to dump that fluid wherever it normally goes. Toilet for body fluids like urine or feces or emesis. Sink for bathing water. Remember, nothing dirty went in that basin. Dirty washcloths went on the side of the basin. That basin just has clean water in it. Doesn't matter what body parts you washed, You did not put a soapy washcloth back in that basin because that would contaminate our rinsing water, right? Make sense? So all that basin is ever holding is water. Good? So we dump our water where it normally goes. Then we rinse the basin and dump that rinse water wherever we put the stuff. Then we set it down. You can't hold it while you're disinfecting it. You can't, because you're not disinfecting it then. You're still contaminating it. So we're going to set it down in the sink and we're going to spray it. Then we're going to pick it up with a paper towel between our dirty hands or dirty gloves and the clean basin. We're going to dry the inside, we're going to dry the outside, and then we're going to put it away using a paper towel to open the drawer. Good? You'll see this 8 times, 8 more times. Okay, throw those paper towels away after you're done. We also learned the closing. The closing has a lot of steps, a lot of steps. So you want to make sure your patient is in a clean and safe environment. Make sure that the bed is in the lowest position and ask if they're comfortable. They need to hear that word, comfortable. You want to make sure that they have something to distract themselves. So would you like a magazine, TV remote, would you like something? This is called addressing preferences. And you want to make sure they're covered. Should I ever see knobby knees? No. So make sure they're covered. Either clothes, that's fine, or sheet, that's fine too, but don't leave them completely uncovered. And then we open the curtain. After we do all that, we make sure that they have their call light so they can get in touch with us. And then we're done with the patient now. All of their cooties, we've cootied up. What do we want to do with those cooties? Yeah, get rid of them. So we're going to go to the sink and wash them off. Now, in some settings, you can use hand sanitizer. That's going to be indicated by your facilities, policies, and procedures. So some settings will say, yeah, you can use hand sanitizer. You don't have to go to the sink. But for the test, we're going to go to the sink because we're being graded on it. Okay, good. If you have to document, you do that after hand washing. Then we wash our hands again because our cardinal rule is end skill with clean hands. Questions on that? Okay. So let's talk about hand washing. You're going to turn the faucet on, wet your hands, and apply soap. You've got to make sure you have enough soap to generate a lather. Once I bring my hands together, the clock starts. How long do I have to rub for? 20 seconds, all surfaces. Keeping my hands lower than my elbows, rub, rub, rub. Then I'm going to go down to my nails and then rinse. When I rinse, I'm going to keep the water in the sink by tapping and then dry. As many paper towels as you need. Then, once your hands are dry, you'll get a clean, dry paper towel to turn the faucet off. Pulse. This is the amount of times your heart beats over 1 full minute. The care plan is going to tell you how long you can count for. So this care plan says 1 full minute, so we'll count for the full minute. The pulse, radial pulse, is located at the top of the thumb side of the wrist. We do not use our thumb to take a pulse. We use 2 fingers. The fingertips, not the flat area. We're going to find the pulse. We're going to look at the clock and say start out loud so the evaluator can count with us. They're on the other side of the patient, the other wrist. And when we're all done with that minute, we're going to say stop. That means that you are counting, but you're also looking at the clock. Don't stare at the clock. This is important. Look up. Find your starting point and then look away. You just want to glance back every so often because your brain is already hardwired to interpret stimuli in a certain order. Your brain will pay attention to what it sees first, then what it hears, then what it feels. Well, we're trying to count what we feel. That's way down on the list. So if we're staring at that clock, and we're watching that second hand move, our brain is going to count the second hand. You guys see how that could happen? So if you get the number 60, I would count again. Because chances are, if you stared at that clock and you got the number 60, how many seconds are in a minute? 60. So chances are you probably counted the seconds. They're pretty predictable. There's only 60 in every minute, always, right? So if you're looking at the clock, you're going to get 60. It's what we feel that we should be counting. Now, yes, the patient may have a pulse of 60. Absolutely. Could happen because our normal is between 60 and 100. But if we get the number 60, it really should trigger, wait, let me recount, especially being brand new, because chances are you counted the wrong thing without even being aware of it. Does that make sense? Okay. That's a documentation skill, by the way. Make sure you document. Dressing a resident with a weak arm. We ask about clothing preferences. We get our clothing first. We lift extremities from below with a flat palm. We make sure that you protect privacy during this. Even though we're dressing them, you really want to maintain modesty there. Undress strong arm first. Dress weak arm first. Put the call light in the stronger hand when you leave. Range of motion exercises. We do these to keep what the patient already has. We're not trying to make anything better. So we don't say something like no pain, no gain. Great question. Okay, and this actually was on one of the Facebook groups this morning. Somebody was asking about this. So when the care plan says right or left, do you think they're talking about the CNA's right or left, or do you think they're talking about the patient's right or left? The patient, and the way we remember that is it's always about the patient. So if your patient has range of motion on the left shoulder, that's their left, not yours. But if you're facing the patient, their left is opposite of yours. Okay? Does that make sense? So if it takes you a while to kind of get your brain like on track with this. So if you have trouble with the patient's right and left, what I do is I look, okay, what wall would she look at if she looked straight ahead? She'd look at that wall, right? Everybody with me? I would stand at the end of the bed and I would look at that wall. Right, left. So when I turn around, I know that that's her right arm. Does that make sense? So if you look the same direction your patient is facing to determine your right and left, because when you turn back around and face them, it's opposite. Good? Makes sense? Great question. Okay, so range of motion. We're doing this to retain function. We lift extremities from below with a flat palm. We move slowly and smoothly. We always return back to start. Flexion extension is up, down. Abduction, adduction, side to side. Rotation, around. Follow the recipe. Hand and nail care. This is a mini-manny. Put the hand in the basin to soak. Put it out on a towel to wash. Put it back in the basin to rinse. Put it back on the towel to dry. Clean under the nails with the slanted end of the orange stick, wiping off in between each nail. File the rough edges with an emery board toward the center, one direction. And then apply lotion last by warming it up and then wiping off the excess. Good? That's one of the easier skills. There's one that's a little bit easier than that one. Just a little bit easier, but you have to get on the floor to do it. So if you have mobility issues like me, that's a little bit harder. All right, making an occupied bed. We learned this last class. We make the bed a half at a time. That's all we're doing here is making the bed a half at a time. Clean rolls toward me, dirty rolls away. Good? Once you put the new sheet on the bed, secure it all four corners, minimize wrinkles under the patient, make sure they're in the middle of the bed at the end, put the top sheet on, tuck it in, get the corners off the floor, change the pillowcase. Pillowcases last because we want to limit the amount of time they are without the pillow.
Why is it that when you put the pillowcase on, the opening goes away from the door?
So that's not a testing checkpoint, okay?
Right.
It's not going to be graded on the exam, but it is a nursing best practice.
Right.
And the reason for that is think about all of the people that walk up and down the hallway. Okay, we have patients, we have staff, we have visitors, a lot of people in that hallway. We have x-ray techs, we have phlebotomists, we have clergy members, we have billing clerks. I mean, think about all the people in a hospital hallway, right? Well, if any of them have an airborne illness, those particles are going to float into that room on air currents. Well, if the opening of the pillowcase is facing in that direction, those air currents can get underneath that pillowcase and get onto the pillow. Well, pillows underneath that pillowcase, warm, dark, and moist, because we tend to drool a little bit while we sleep. Or our eyes can even secrete a little bit, or we sweat. So underneath that pillowcase is warm, dark, moist. Well, if we allow pathogens under the pillowcase, that's the ideal breeding environment for them to proliferate, and that's can lead to this. And it's very strange that I actually lived in a time that I could see this. This was an important principle back when we were battling tuberculosis in the early 1900s, because tuberculosis was airborne, right? So this was an important principle. We made sure that there were no pillowcases facing a doorway, openings facing a doorway, right? But then we kind of got control and we didn't have too many airborne illnesses. We pretty much eradicated measles, which is another airborne illness. So up until 2020, we really didn't have a whole lot of airborne illnesses to worry about. So people quit paying attention to which direction the pillowcase was pointing, right? And then along comes, what happened in 2020? Anybody know? COVID. And COVID had an airborne quality to it. In fact, for a long time, we weren't real sure. Is it airborne or is it droplet? And I think the jury is still out in some cases about this. I don't know that they ever made a definitive ruling on this. Well, now all of a sudden, we're completely out of practice with the pillowcase thing, right? And now we've got an airborne illness in our facilities. So this became a really big deal again. And thankfully, we had some really old nurses that were still working that said, hey, we remember, right? Back in the 70s, the 80s, this is what we did. So maybe we should do that again. And I'm not going to say it helped. I don't know. I don't think there's been any actual studies on it. But in my mind, certainly can't hurt. It's a step that we can take to keep our patients just a little bit safer. So that's why that's a principle. Pretty interesting, isn't it?
Yeah,
Okay. Try to minimize the amount of wrinkles under the patient. Look how much you guys have learned. That's a lot of information. It's a lot of information. Any questions on any of that before we move on? We good? All right. So right now, if we're keeping track, I told you on day one, you were going to learn all 11 principles on the back wall. And if you're keeping track, we're down to just one left. Just one. So we're making good progress. Now, from now on, once we learn this last one, we're just going to use all of these principles and recycle them. We're just going to recycle them. We're going to say, okay, this skill that we're going to learn is going to follow the care plan. We do our opening. We use the barrier rules. We'll evaluate if we need gloves. This skill doesn't need a privacy blanket, but we do need to look at linen rules, okay? Just going to mix and match all of these principles and use them over and over and over again. The really cool thing about learning the skills in this method, this manner, is that later on in life, you might need to learn some new skills, depending on where you're working. And if you know these principles, you already know half of the skill, okay? Do you completely take off the dirty linen before putting the clean on? No. Great question. No, because we never want our patient to lay on a bare mattress, okay? Can't have a patient on a bare mattress. So what we're going to do is change the linen a half at a time. We loosen the corners on the side we're working on. We roll that toward the patient. We put the clean one, secure the corners, roll it toward us, and tuck it under the dirty. We put the patient back on their back, go around to the other side of the bed, turn them on their side. We take the old one off, smooth the new one out, secure the corners, and the patient never landed on the bare mattress. So I hope that helps. All right. Any questions? Any questions? Remember that we have the care plan sets available. We have the full ones, which are the yellow sheets, and the checklists are on the back. Or we have the little pocket cards that you can get for, they're up here. I've got pocket cards up there. Those pocket cards are just the skills. They don't have the checklist. They're just the skills. But they're available for you as well. Remember, you have all of this in your book. All of this is in your book. The care plan sets are on page 25, and the individual care plans are at the top of every skill. You've got all this. It's, do you want to make your own flashcards, or do you want to buy the ones that are pre-made? That's really your question here. Okay. Good? Good. All right, so let's go to page 138 and learn side lying position. Okay, for this skill, side lying position, page 138, down here you can see all of the skill or all of the principles that are going to govern this skill. They're all spelled out for us here. So if you couldn't remember what the opening was made of, it's right here. If you can't remember the rules of the barrier, they're right here. I don't make you go all the way back to page 27 to look them up. They're right here on the page for a quick review. Good? Down here is our test-specific information. Somebody with your level of experience should be able to turn somebody onto their side and use some pillows to keep them there in 8 minutes or less. Now, a lot of these skills, I've told you that it's way more time than you actually need to do the skill, that they've really overestimated. This one's pretty close. Right? They don't give you like a ton more time than you need. So this is one that I absolutely would practice because the timing is a little bit compressed. And if you're not real sure what you're doing and you're fumbling and you're starting over and starting over and starting over, you might run out of time. So this is one that I definitely recommend that you practice before you test, primarily because the timing is pretty tight on it. This is going to be another live testing student. That person will be positioned in bed at the beginning of the skill. It's not a documentation skill. If you go to page 139, we can see our step-by-step instructions listed here, our care plan at the top, and our supplies at the bottom. So, I want to show you something with this, right? These are all step-by-step instructions. If you look at the end of the lines, you'll see a little number there. You see 15A, 1, 15B, 2, 15C. You guys see all those? Okay, that tells you on the checklist what checkpoint you're getting checked off. So if you have these, if you purchase these with all of the checkpoints on them, if you look at the first one, knock 15A, look at line 1, right? Read care plan, knock 15A. So if I looked at this is change position, supported sidling position, and I look at 15A, it says announce self or knock before entering room. So I'm getting that checkpoint checked off by doing that step. So what those little numbers do is they bring this step-by-step instruction into line with the checklist in a way that you can cross-reference to verify. Okay, good, good. And I bring that up because sometimes students will say, well, wait a minute, why am I doing this? Why do I need to do this step? If you understand that it's a graded checkpoint and what graded checkpoint we're getting checked off, it can help you understand why that step might be important. Good? Questions? Okay. Supplies are at the bottom of the page. So here's our care plan. Position the resident on his left side. Patient requires support to remain on his side and is unable to assist with turning. So all we're doing here is turning a patient, using some pillows to keep them in that position because gravity will try to pull them back, and making sure that they're comfortable. That's really what this skill is about. Now, our care plan does not say this patient is immobile. It does not say this patient is paralyzed. It does not say this patient can't move on their own. It just says position the resident on their left side. So remember, we follow the care plan, the whole care plan, and don't put that into this care plan. The care plan does not say the patient can't move. It just tells us what to do with the patient. Does that make sense? A lot of people make the mistake of thinking, oh, this must be a paralyzed patient if I'm turning them. Not necessarily. What if the patient just had major abdominal surgery and the two halves of their tummy are not talking right now? They're not going to be able to flip themselves on their side. That's not a thing, right? Make sense? So we don't know why this patient can't turn on their own. We have no idea. Our care plan does not tell us. Another question I get asked quite often is, when you're a CNA, do they tell you what your patients have? I mean, do you get to know what they're dealing with, what their diagnoses are? And the answer is no, you don't, and you don't need to. You don't need to. Because we treat every patient as if they already have a communicable disease. That's called universal precautions. So I don't need to know if you've got HIV to treat you as though you have HIV. I'm not touching any of your body fluids without an extra layer. I'm also going to wash my hands before and after, right? I don't need to know. I'm not going to treat that HIV patient any differently than I would treat you. There's no risk elevation there because you might also have HIV and just don't know it yet, right? Unfortunately, when we get sick, when we get a disease, we don't always know right away. You don't like wake up and get an alert on your phone saying, caution, you are now, whatever positive. I mean, it doesn't happen that way. Your body tries to fight it off. You develop a few symptoms. You wait to see if they're going to go away. Then you go to the doctor and complain to the doctor, and then they order some lab work or maybe some medical imaging, and we have to wait for those results to come back. Then you've got to go back to the doctor to get your follow-up results. I mean, that's a whole lot of time that you could be contagious and nobody knows it yet, right? So I'm treating everybody as if you've got something. I'm not going to touch your body fluids without gloves. But if it's intact skin, stuff doesn't get through the skin, so we're okay there. As long as I wash my hands before and wash my hands after. All right, so don't put anything into this care plan that isn't already there. But I am going to talk to you a little bit about immobility because it is kind of a special case that we do have to discuss. So if you look at all of the principles, we know skill rules. We know the opening. We know glove rules. We know how to use a barrier. We know when to use a privacy blanket. We know how to treat our linens. We know to keep our patient in the middle of the bed, and we know how to do the closing. We know what we need to know to do this skill, except for our skill-specific steps. Good? Okay. But before we get there, I want to talk just a little bit about immobility because they do require a little bit extra work. Immobility, that term, means unable to move on their own. Now, you can have immobility of one arm, unable to move that arm on its own. You can have immobility of half of the body. You can have immobility of just the lower half of the body. Or you can have immobility of the entire body. Depends on what's going on with you, okay? But immobility means that patient cannot move on their own. They need some help. Well, if somebody cannot move on their own, can they take care of their own bathroom needs? Can they feed themselves? What do you guys think? If they cannot move on their own, can they feed themselves? No. If they cannot move on their own, can they change their position? No. If they cannot move on their own, it means they can't do anything on their own, which means that we are doing everything for this patient. This is what we call a total care patient. Okay? We're feeding them, we're bathing them, we're dressing them, we're doing their mouth care, we're doing everything on them because they cannot move on their own. Yes? No? Okay. All right. But I want to talk to you about why this is difficult for your patients themselves. So when we have immobility, it doesn't just affect one part of the body. It actually affects every single organ. You know, all those organs that you learned about in Chapter 4, immobility affects all of them. It affects how much your lungs can expand when you breathe. It affects the secretions in the bottom of the lungs, and they actually tend to get hard. It affects your digestion because for food to move through your small intestine, it requires outside muscle movement. So your small intestine is what we call smooth muscle, but it doesn't really move much on its own. So when you eat and the food goes through the stomach, it goes into the small intestine and it kind of floats slowly, sluggishly, doesn't really move much on its own. But when you breathe, that moves your tummy muscles. When you get up and walk, that moves your tummy muscles. When you sit up or lay down, that moves your tummy muscles. And those tummy muscles contracting and relaxing is what actually moves the food through your digestive system. So if you're not moving and those tummy muscles aren't doing a whole lot, that stuff that's in the small intestine will kind of get stuck, and our patient is going to be at risk of constipation. But also, they're not going to absorb as many nutrients either. So nutrition is going to be very important for these individuals. That all sounds pretty bad, right? I mean, being stuck in bed, that sounds pretty bad, but it gets even worse because your bones start to be affected. They become brittle because your body actually goes mining for calcium and phosphorus in your bones. It chips away at your bones. It makes like they look like sponges to get that calcium and phosphorus that it needs. That doesn't sound like any good, right? It affects your brain because in order to get, your heart's here, right? Brain's here. So in order to get blood from your heart to your brain, it's got to really pump. Well, laying down, you're not really pumping all that hard. So that means that we're not going to be able to push a lot of blood to the brain, and the brain isn't going to work quite as well as it used to. Good? Makes sense? Boy, that's a whole lot of problems. We didn't even talk about muscles, which everybody knows about, right? Your muscles will atrophy, they'll shrink. We didn't even talk about that. But there's one organ more than any of those that gets affected by immobility, and that is your skin. Your skin is the most affected, or now I just gave you a whole laundry list of bad stuff, and I'm telling you that the skin is even worse than all of that. So how does that work? So in order to understand this, I need you to play along with me. We're going to do a little experiment. I want you to put one of your hands underneath your leg for the next 2 minutes. I want you to sit on one of your hands for the next 2 minutes. You're going to want to pull them out. I'm going to ask you to play along, please, okay? Because I want to show you something. I'll let you know when your 2 minutes are up. So when you are laying down, and immobile patients are usually in a prone position, a laying down position, or I'm sorry, supine position, you have pressure points where your bones contact the surface you're laying on. So the back of your head, your shoulders, your elbows, your hips, or lower back area, the backs of your thighs, backs of your calves, and your heels. These are all areas that are compressed against the bed surface. Can you guys see that? These are called pressure points. And the ones under bones are really at risk. These are under bones, but they're not under bony prominences. They're not under where the bones end. So these are our problems, but not nearly as much problem as this or this. So why do we care? Well, when we have a bone that is pressing down and we have a surface underneath, so I've got a bed and I've got a bone, gravity is going to pull that bone down to that surface. It's gravity. It's what it does. Well, what's caught in between that bone, which is heavy, and the surface, which isn't moving, what's caught between them is your muscle, your fat, and your skin. Now, where this goes wrong is that in these layers, you have blood vessels. So when that bone gets pulled down onto muscle, fat, skin, and vessels, it compresses those vessels down. I know you want to pull your hands out now, don't you? Not yet. It compresses those vessels down and closes them off like a straw. It's no different than if I did this with my straw. It closes it off. Now, what do you think happens to tissue that doesn't get good blood flow? It dies. It dies because it's not getting nutrients. It's not getting oxygen. It's not getting what it needs. It will die. And that's very, very bad for our patients because dead cells don't hold on to their friends. They let go. And we end up with pressure sores. Now, this is further exacerbated if the surface that they're laying on has wrinkles, because now we're not just laying on a flat surface, we're laying on a hilly surface, and where that skin contacts that, you're going to have areas of increased pressure pressing up into that skin. Does that make sense? That doesn't sound like any good, does it? So all of these layers that are caught in between your flat surface and the area of pressure are going to be affected. So go ahead and take your hand out and take a look at it. I want you to look really closely. Do you have color changes? Anybody see a color change? Okay, now look really, really closely. Really close. Do you see the pattern of the chair or your clothing pressed into your skin? Can you see the pattern? That was 2 minutes. Oh, I forget. I can't hold up a V sign. Gives me balloons. That was just 2 minutes. Now, can you imagine how deep those lines would go if you left that hand there for hours and hours and hours? In 2 minutes, you have an imprinting on the skin. As that area stays under pressure, that surface that you're on is going to play more of a part because remember, gravity's pulling that bone down. So those layers in between are going to get more and more and more and more compressed, and the area that you're laying on is going to cut up and up and up and up further. Bed sores can occur in as little as 2 hours. 2 minutes gave you guys lines. 2 hours can result in a full separation of skin integrity, bed sores. So if we've got a patient who is immobile, unable to change their own position, we have to understand this, because there's some big, big problems with leaving that patient in one position for a long time. Good? We got lines in 2 minutes. And you're healthy. You're healthy. Our patients aren't healthy. This is why when you go to bed at night, you change position. You don't end in the same position as you started. You don't lay down, close your eyes, go to sleep, and wake up in exactly the same position. Your brain will make you change position. It'll make you toss, turn, stretch, move, and it's all to relieve pressure. That's why you move, to relieve pressure. Does that make sense? Everybody with me on that? Okay. But this isn't just limited to you in bed. Right here in these chairs, you change position. Not a single one of you is completely still. You're jiggling your foot, you're laying back in your chair, you're putting your hand, you're crossing your arms, you're doing all kinds of things to change position because your muscles are getting tired of being squished. So they tell you, scoot around, move around. I'm uncomfortable here, right? So you do this without even realizing it, without being aware of how much you're moving. And that's all designed to keep your body in tip-top shape. But what if we can't? What if we cannot move? Somebody's got to do that for us. Does that make sense? Good? Okay, so patients that cannot move on their own must be turned every 2 hours around the clock, or as often as directed in the care plan. If our care plan tells us to turn a patient every hour around the clock, what are we going to do? Turn them every hour. Are we going to argue? Well, it's normally every 2. If I'm the nurse and I'm working with a patient, and when I was in hospice, I used to do this a lot because our hospice patients are really at risk. Last thing I want to do when somebody's in the process of dying is giving them a painful bed sore to deal with on top of that. That's awful. We shouldn't do that. Bad enough what they're going through, right? So my care plans for my patients that were in the dying process, they're not moving. We're turning them every hour, and we're getting them comfortable because they're not taking in nutrition. They're not getting good protein. And without good protein and good hydration, this process speeds up. Okay, make sense? So we always go by our care plan. Yes, on a general basis, we're going to change this patient's position every 2 hours around the clock. But this can be modified by the care plan based on the needs of that patient. Good? Questions? This is a turning clock. So when we have a patient that is immobile and we have to turn them every 2 hours, you can make this. CNAs are allowed to make these and put them up in the room. A turning clock keeps everybody on the same page. So if I am the nurse and I walk in the patient's room at 1 p.m., 1 in the afternoon, this is when I walk in the patient's room. I should be able to look at the turning clock and see the patient should be on their right side. I look at the patient. Is she on her right side? No, that tells me something went wrong. So I'm going to put her on her right side, and then I'm going to go find the CNA and say, hey, what went wrong? What happened? Patient was supposed to be on their right side. I got him there for you. It's good. We're in good shape, but this needs to be a priority, guys, because the skin isn't going to understand that you're running late. This is a priority. So let's talk about prioritization for just a minute when it comes to CNA work. Guys, you're going to have more to do then you have time to do it. That's just a fact of medicine right now. We give our caregivers way more to do than they physically have time to do. It's horrible. And you should be complaining to your CEOs about it. Because the more that they can get you to do, the bigger their bonuses are at the end of the year. So they are profiting off of your compliance. You guys understand that? Okay. So prioritization is going to matter here. Priority number one is safety. If any of your patients are unsafe, that has to be dealt with first. Top of the line, safety. The next thing down is toileting. If your patient hits a call light, says, I have to go to the bathroom, you can't say, yeah, I'll get to you in just a little bit. Because one of the changes of aging that you read about is a decreased bladder capacity and a decreased ability to hold it. That's a normal sign of aging. So if you tell your toileting patients, yeah, I'm feeding somebody right now, I'll get to you in a little bit, that patient may not be able to hold it. Okay, so toileting is safety number one, toileting is number two. Number three is meals and appointments. Okay, everything else comes after that. Those are our prioritization. Now, I am going to give you one caveat to that, though. Okay, there is one modification to that, and that is vital signs if needed for medication administration. So sometimes a nurse will say, hey, I need pulses on these 6 rooms before 8 a.m. because I'm passing meds. Well, now you know what your time, because a 9 a.m. med pass starts at 8 and ends at 10. Okay, so they need those pulses by 8 a.m. Well, first we look at safety for our patients, then we toilet who needs to be toileted. We get people to meals, but in there, you're going to have to be doing your vital signs for medications. Make sense? Okay. Not all places, and I want to be very clear on this, not all states and not all places allow CNAs to get vital signs for medication administration. A lot of facilities will only let CNAs do vital signs for screening, for non-clinical care, just, you know, how's everybody doing type thing. Make sense? Good? Okay, Elsabet says, hello teacher, I need Learn for Here, but do you have online class certificate? So the answer to that is very complex. The online course is giving you the information you need to pass the state exam. Once you take the state exam, that's your certificate, okay? So in order to get a CNA class certificate, you have to go to a state-approved CNA program. And that's not us because we don't do clinicals. So if you're looking for a state-approved certificate, which doesn't negate the need for the test, it just opens the door for the test, then you would need to go through a school near you, okay? We're giving you information, not certification. All right, so you guys are allowed to do this. Oh, real quick. When we're changing position, we start with the patient on their back, we turn them to their right. 2 hours later, back to their back. 2 hours later to the left. Back, right, back, left, back, right, back, left. Notice on here, it does not say on their stomach. Does not say on their stomach. The care plan would specifically have to tell you to put the patient on their stomach in order to put the patient on their stomach. And that's because in some cases with immobility, it keeps the patient from being to move off of their rib cage enough to inflate their lungs, and you can suffocate them. We don't put immobile patients on their stomach unless the care plan specifically tells us to. Okay? There are exceptions to that, but that would be in the care plan. Good? Okay, so when we are caring for a patient by turning them on their side, we want to make sure that we do it with the scoot and roll method. So we're going to get the patient close to us on the edge of the bed. We're going to position their arms and legs for the turn, and then we're going to roll them away from us so that they're in the middle of the bed after the turn. Scoot and roll. Okay. Remember, you don't want them near the edge of the bed. So we'll scoot them toward us. Now, a question I get asked a lot is, well, what if they can't scoot on their own? What if they are immobile? Well, you can move them in segments, head and neck, torso, hips, legs. You can use a draw sheet, which a draw sheet is in your book on page 140. You can see what a draw sheet is. Draw sheet is a flat sheet folded in half lengthwise and used as a sling under the patient to move them. You can use a slide sheet. You can use a lot of different methods. If unsure what method, what should you do? Ask the nurse. Absolutely. At the end, they should be in the middle of the bed. So this is one of the most misunderstood steps of this skill during the exam. This skill is not about how well you turn them. It's about where they are after the turn. If you did the best job in the world of turning the patient, but they're near the edge of the bed, you don't get credit for it. So after you turn this patient, you've got to step back and look. Are they in the middle of the bed? If not, stop. Do it again. Scoot them toward you. Roll them on their side. They need to be in the middle of the bed. And then put your pillows in place to keep them there. Good? You can use a draw sheet to help you with that. Now, how do we get this patient on her side if she can't really move well on her own? There's a way for us to prep the patient for turning. And if I just came up here and tried to turn this patient on her side, it's going to be a lot of effort for me, but also for her. So if I just put my hand on her hip and her shoulder and just tried to kind of manhandle her over onto her side, that actually risks injury to me. And I want to set this up where I'm not going to be injured, but neither is she. And that's what this is all about. So when we're going to turn a patient onto their side, so this care plan tells me to turn the patient on her left side. Which is her left? Okay, so I'm facing, if she were to sit up, she would be looking at that wall, right? This is my left. This is her left. So that means I have to turn her onto this side, onto her left. Should I be standing on this side of the bed or that side of the bed? That side of the bed, because we turn a patient away from us. Got it? Got it? Okay, so because of camera angles, we're going to pretend I'm over there. So if I'm on that side of the bed, the furthest arm away from me goes above the head. Furthest arm away from me. If I were turning her on her right side, I would be on this side of the bed, and the furthest arm would be this one. Furthest arm above the head. Closest arm crosses the chest. Furthest arm up, closest arm over. This is how our patient would look, turning to her left side. Furthest arm up, closest arm over. This is how she would look if I were turning her on her right side. Good? Good? Okay, let's move to the legs. Closest knee to me is going to be bent with a foot flat on the bed. Closest knee to me is bent with a foot flat on the bed. Furthest knee from me is angled out, laying on the bed. Okay, so closest knee is tented, furthest knee is angled out. Good? Good? When you get the patient in this position, furthest arm up, closest arm crosses, closest knee bent, furthest knee angled. When I get the patient in this position, I put a hand on the hip, one on the shoulder, and I just roll them on their side, and they go, oh, so easy. Super easy. Because we've already gotten most of the weight going in the direction we need it to go. We're not fighting the weight. Okay. Is this following Connecticut state regulations? Yes. Connecticut uses Prometric as your testing agency. Everything that we teach is based on Prometric standards. So everything that we're providing will help you pass Prometric's exam. But in Connecticut, you still have to take a state-approved CNA course to be eligible for testing. Florida, you can challenge. Yay. Makes it easier for us. All right. So we're going to position this patient for turning. Since we're turning them onto their left side, furthest arm up, closest arm crosses, closest knee bent, furthest knee angled. We have them in the right position. We've scooted them a little bit closer to us so that after this turn, they should end in the middle of the bed. Okay, middle of the bed. Once we get them in that position, we're going to take a pillow and place it behind the back in a roll. This is the hard pillow, guys. This is the hard pillow because it's going to want to pop out at you. It's the hard pillow. So you're going to tuck one edge of the pillow behind their back, roll it up, and then tuck the other edge of the pillow behind their back to make that roll. And that roll is what's going to keep them from rolling back onto their back. Remember, gravity is always trying to pull people back to their back. Once we get that back pillow in place, we're going to put one between the legs, specifically between the ankles and the knees. You don't want those bony areas rubbing together. The top leg should be just slightly offset from the bottom leg, so they're not laying directly on top of each other. They're just a little bit offset. And then we're going to put a pillow under that upper arm. Make sure it's not covering the face, guys. But this under the elbow and wrist, like this, puts that arm in a neutral position. It relieves the pressure along the shoulder and into the neck, which can cause muscle spasms and headaches. So we want to support that top arm. And then the bottom arm, this one is going to be tucked under that pillow, and we want to make sure that pillow is under the head, not the shoulder. So we adjust that pillow and then put that bottom arm underneath it. This is one of the most comfortable positions you will ever be in. It's awesome. Gives you support in all the right places. Now, at the end, you want to make sure that that bottom arm is not hanging off the bed. And we're going to put the call light directly in that bottom hand. If you try to put the call light in the top hand, you're going to extend that cord across their neck. That's a safety issue. So we put the call light in the bottom hand. Good? All right, so now we know everything we need to know to do this skill. Let's check off our checklist. The first thing we're going to do is read our care plan. Then we'll do our opening and get those check marks. Then we'll evaluate if we need gloves. We might. For the test, your patient is fully clothed and holding onto all of their own body fluids like a champ. So for the test, gloves are not indicated. If you wear them, if you decide to wear them, and you can, if you decide to wear them, you will be graded on removal. You just added another checkpoint to your checklist. So keep that in mind. We're going to use a privacy blanket because our patient is uncovered or undressed at this point. Linen rules apply. Don't snap or shake anything. We're going to make sure the patient is in the center of the bed. We're going to do our skill-specific steps. And then we're going to do our closing and get those check marks. So when you're looking at this, less than half of the skill has to do with the actual skill itself. The rest of it is all stuff we already know. Now this care plan is only for this patient, not for these guys. This patient turns herself. She's bedbound, but she moves around in bed all by herself. This patient isn't bedbound. She gets up all day, every day. And this patient, he has to be turned every hour, not every 2. So care plans are going to be different. Good? Good. All right, let's go ahead and take a look at this video. It's got good close-ups of those pillow placements. Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I need to turn you onto your left side and use some pillows to secure your position. Is that okay?
Yes.
Okay, I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. Now that I have clean hands, I'll get clean supplies. We're going to start with a barrier, and we'll place it on the overbed table. And this gives us a clean place to put our clean supplies. Now I'll get 3 pillows. And a privacy blanket. We'll bring this over to the side of the bed. Okay, Mr. Jones, I'm going to start with a privacy blanket. I'll place this on top of you to help protect your privacy and to keep you warm while we do this skill. So I'll take the privacy blanket and unfold it, being careful not to snap it or shake it. We'll lay it right over the patient on top of the sheet. Can you hold that for me? Thank you. I'm going to pull the sheet all the way down to the end of the bed. This just gets that sheet out of our way. Okay, Mr. Jones, can you scoot your body toward me? Thank you. Now I'm going to position you for the turn. So we're going to take the furthest arm and place it up over the head. The closest arm will cross the chest. The closest knee is going to bend with the foot flat on the bed. And then the furthest knee will angle out. Okay, just relax for me. Thank you. And now I'm going to roll you on your side on the count of 3. 1, 2, 3. So I'll roll the patient, maintaining a wide base of support. And then I'll use some pillows to keep him in this position. So the first pillow will go behind the back. We're going to move the privacy blanket out of our way so we don't tuck it in. The first pillow will go behind the back. We're going to tuck this edge underneath the patient. So I'm going to tuck down and under. This edge will roll up and then under the patient, down and under. And that provides a nice roll. We'll go to the other side of the bed. So this pillow will go between the legs, specifically between the knees and the ankles. We don't want the legs to lay right on top of each other, so I'm going to move the top leg just a little bit forward, and then I'll lift from below and place the pillow in between the legs. That way they're not laying right on top of each other, and the bony prominences are separated by the pillow. We'll cover the patient up. I'm going to take the third pillow, and this one will go underneath this top arm. As the arm droops down, this puts a lot of pressure along the upper back and into the neck. We need that arm in a neutral position. So I'll take the pillow, lift the arm from below, and place the pillow right under the elbow area of that top arm. Now the pillow under the head is under the bottom shoulder. So we're going to lift the head up, move the pillow so that it's only supporting the head and neck, and then we'll place that bottom arm underneath the pillow. We're going to take the call light and place it directly in that bottom hand. Okay, Mr. Jones, I'm going to remove the blanket and pull the sheet up now. So we'll pull the sheet right up over the blanket and the pillows, and then remove that privacy blanket, rolling it into a ball as we remove it so that trailing edges don't contaminate other surfaces. We'll adjust the sheet for neatness and appearance. And we'll open the privacy curtain. Mr. Jones, are you comfortable?
Yes.
Okay, I'm going to go dispose of my linens and I'll be right back. This will go into dirty linen. We'll dispose of the barrier in the trash can. And we'll move the tray table back to storage. Okay, Mr. Jones, is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes, ma'am.
Okay. Is the head of the bed, does it need to be adjusted at all?
No, thank you.
Your environment is clean. Bed is in the low position. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. Oh, sorry, I forgot to warn you. I'm sorry. All right. Any questions on that skill? This is one you probably ought to practice. The good news is if you have a live person at home, it's not hard to get somebody to practice this with you because you're making them very comfortable and there's nothing too weird about it. So this is one that you usually can get somebody at home to practice with you on. All right. The next skill we're going to do is foot care. This is going to take me a little bit of time to go over with you, so we're going to take our break a little early today and get that out of the way because once I get into foot care, I don't like to stop in the middle of it. Okay? Sound good? All right, let's go on break. Okay, we're back at it. Foot care is our next skill. If you go to page 118, you can see the overview of this particular skill. All of the principles are listed here and detailed here for us, along with our skill-specific steps that we need to know. Down here is testing information. Somebody with your level of experience should be able to do this in 13 minutes or less. 13 minutes or less. The time for this is very generous. Very generous. This is going to be another live testing student. So that means that somebody in here will probably be a patient for this skill. And I get it. Nobody likes their feet touched. I understand that. Some of you are extremely ticklish like I am. I can't get a pedicure because I laugh so hard. But if you are assigned to be a patient for this skill, you need to just be a patient for the skill. Go to your happy place, whatever you need to do, okay? Because the person that's being tested, if they don't have a patient, they can't do the skill. And if they can't do the skill, they're not going to pass the test. Okay, good? All right, so page 119 tells us our skills-specific step-by-step instructions along with the care plan at the top, supplies at the bottom, and here's our care plan. Provide foot care to one foot using soap and water. The resident is sitting in a chair and their sock and shoe should be replaced at the end of the skill. I want to explain each part of this individually. How many feet are we washing? One. Why? Care plan says. What if the patient has two? We're only doing one. So don't do the second foot to get extra credit. You're actually not going to get extra credit. You're going to get penalized for not following the care plan. It also says that their sock and shoe should be replaced at the end of the skill. And I want to talk about that really quickly. In a clinical setting, you're going to have access to the patient's socks and shoes. So when you're done doing foot care, you're going to put a clean pair of socks on the patient. That makes sense, right? Right? But for the test, you guys are going to be the patient and you don't have a clean set of socks on you. So what this is doing is removing any confusion for the person performing the skill. Because you know, clean feet need clean socks, but the patient doesn't have clean socks, so what do? Well, our care plan is telling us exactly what to do here. Put the patient's sock and shoe back on. So for the exam, you get to pick. But we need that latitude just in case the patient has a cast on one foot or, you know, something crazy during the test. That way the evaluators have the choice of being able to decide which foot. All right, the principles that govern this skill, we know all of them. There's nothing new to learn for this skill. Nothing new to learn. We do want to look at our skills-specific steps, though. This is so much like hand and nail care. I mean, it's a lot like hand and nail care. You guys remember hand and nail care? For hand and nail care, we soak the hand in the basin. For foot care, we're going to soak the foot in the basin. For hand and nail care, we moved the hand out of the basin and put it on a towel. For foot care, we're going to do the same thing. For hand and nail care, we wash the hand. We're going to wash the foot. We put it back in the basin to rinse. We're going to do that with the foot. We're going to take it out of the basin, put it on a towel to dry. We're going to do that with the foot. This is where it gets different. For hand and nail care, we cleaned under the nails and filed the edges. For foot care, we're not going to do any of that. We are going to look, though. The whole purpose of this skill is to look for abnormalities. And that's because feet are normally covered in socks and shoes, especially in a clinical setting. We don't like bare feet in a clinical setting. So chances are if this patient has any sort of a wound or a rash or a sore or anything, nobody's going to know about it because the foot is covered all the time. Make sense? That's why we're doing this, is to look at the foot. We're not cleaning the nails. We're not filing the nails. We're not trimming the nails. We're washing, rinsing, drying the foot, looking at the foot, and then we'll apply lotion just like we did with the hand. The one difference here is that we don't put lotion between the toes. Lotion holds in moisture and traps body heat, so we end up with warm, dark, moist between toes. That's not good. Athlete's foot. So dry between the toes, no lotion between the toes. Good? Good? Okay, so all of this has to be done on a foot. We're not going to use the bedside table because patient can't get their foot up on the bedside table to use it. So this skill is going to be done on the floor. So the barrier goes on the floor. Your supplies go on the barrier on the floor. You have to get down to the floor to be able to do this skill. That's the hardest part of the skill, is getting down and then back up. The rest of it, you're soaking the foot, washing the foot, rinsing the foot, drying the foot, lotioning the foot, looking at the foot. And they give us 13 minutes to do that. So way generous on their time. Good. When you're moving the foot, support it. Wash, rinse, and dry the entire foot. Apply lotion, but not between the toes. Look for abnormalities. Keep the foot on the barrier. Foot does not go on the floor. It goes on the barrier. And then we're going to put the sock and the shoe back on. When we put that sock back on, we don't want wrinkles. We don't want wrinkles. So make sure the toe seam is over the toes. There's no wrinkles. The shoe is fastened appropriately. You know, all those things. And then make sure your patient looks comfortable at the end. Okay? Good? Questions?
When you say you have to get down on the floor, do they want you like on your knees, or can you sit on your
Okay.
bottom?
Either. They don't care. Because remember, your uniform is not considered clean once you start work.
Right.
And this is one of the reasons why.
Okay.
Now, you could put a barrier on the floor to kneel on if you want to. That's fine. No problem there. You could put a towel on the floor to give you something a little bit softer. That's fine. If you want to sit on your bottom, that's fine. They're not picky about that. My own personal opinion is they should have those little rolling stools
Right.
to use. That's body mechanics. I think that should be something that's implemented, but they don't ask me, so, you know. They're not grading on how you get down or back up. Okay, so we're going to use all of those principles to check this off. But before we do that, I want to explain to you just a little bit about why we're doing this skill. And I'm going to keep this super brief, all right, super brief. But if your patient has diabetes, which we're going to talk about in a future lesson, if your patient has diabetes, they may potentially have a wound on their foot that they don't even know exists. Now, if you had a wound on your foot, if I stepped on a thumbtack, I would know there's a thumbtack in the bottom of my foot. And I would hop around until I could get that thumbtack out, and I would tell everybody I came into contact with, you know what happened to me? That hurt, right? I would know it. But when your patient has diabetes, specifically long-term diabetes, that excess sugar can actually interfere with the signal from the foot to the brain. It coats the nerves. So the foot would know there's a thumbtack there. Foot's like, hey, brain, red alert, we got a problem here. But that signal can't get up to the brain because the nerve that's supposed to take it there is all gunked up and the signal can't travel. So when we have, this happens more in the hands and the feet because of gravity. Sugar is a heavy molecule, gets pulled down to the hands. They're the lowest part of my upper body, gets pulled down to my feet, right? So those nerves are going to be affected the most. So that's why we do hand and nail care, and that's why we do foot care, is to look for abnormalities that your patient may not even know exist. Does that make sense? Good. So with foot care, do a good job on the looking part. Okay. So we're going to follow our care plan. We're going to do our opening. We're going to evaluate if we need gloves. Now let's time out here for a second on the gloves. Remember I said earlier today that if we are going to touch body fluids, personal skin, or non-intact skin, we need gloves. But I also said if we might touch body fluids, personal skin, or non-intact skin, we need gloves, right? If there's a maybe, we need gloves. You guys remember that? Well, remember that feet are always in socks and shoes. We don't know if there's a wound. We're there to see if there's a wound. So that is, by definition, a maybe. So do we need gloves for this guy? Yes, because it's a maybe. Good? Good. Are you seeing how we're building on what we learn? Okay. So we're going to use a barrier, but this time our barrier will be on the floor. We're going to use linen rules, right? I'm going to, whatever I take, I use. If I don't use it, I lose it. Nothing on the floor either. On a barrier is fine, but nothing on the floor. We're going to follow our washing rules. You guys remember these washing rules? We're going to use paper towel to turn the faucet on. We check it. They check it. No soap in the basin. Whatever we wash, we rinse. Whatever we rinse, we dry. And if you put lotion on, you wipe off the excess. Okay? We're going to clean our basin like we clean everything else. Rinse it, dry it, put it away. We're going to do our skill-specific steps. All right, time out here. Do you see this? Do you guys see this? Right? Most of our steps for this skill are things that we already know. We only have 1, 2, 3, 4, 5 steps that are related to this specific skill. That's crazy. There's hardly anything about foot care that they're actually grading you on for foot care. Everything else is stuff we already know. And then we're going to close the skill like we close everything else. This care plan is only for this patient, nobody else. If your patient goes to a shower regularly, foot care is usually done in the shower as part of the bathing process. If the patient doesn't shower regularly, then we may be assigned to do foot care. If your patient has diabetes, we may be assigned to do foot care in addition to showering. Every patient's going to be a little different. All right, let's go ahead and watch this video. I do not demonstrate this live in class because I can't get on the floor anymore. Hello, good afternoon, Mr. Jones. My name is Patty, and I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I'd like to perform foot care on your right foot per the care plan. Is that okay?
Yes.
Let me close your privacy curtain, wash my hands, and get my supplies, and I'll be right back. After washing my hands, we'll gather our supplies. We're going to start with a barrier on the floor under the patient's feet. So we'll spread the barrier out. And can you move your left foot to the side, please? Thank you. I'm just going to place this barrier on the floor. If you can lift your foot. Thank you very much. And we'll move that shoe out of the way. We'll also need a basin, soap, and lotion. Once the barrier is in place, we're going to get 1 towel and 2 washcloths and take them to the patient's area. You can place a barrier on the floor to kneel on, but this is optional. All right, Mr. Jones, I'm going to go get some water in the basin. I'm going to use a paper towel to turn the water on. Check the water temperature with the inside of my wrist. It should feel warm, not hot or cold, just warm. And we'll fill the basin about 1/4 of the way full. and then throw the paper towel away. Mr. Jones, would you like to check the water temperature?
Oh, that's beautiful.
Very good. I'm going to set this down. For this skill, I need 1 set of gloves. I'm going to go ahead and put my gloves on before we get started. And then I can take your sock off. We're just going to lift your foot and remove your sock. We'll set your sock to the side, being careful not to overextend, and place your foot into the basin. After your foot has soaked for a few moments, I'll place the washcloths in the basin and rinse your foot, and then lift the foot out and place it on the towel, wringing out one of the washcloths and applying soap. We'll apply soap to the top leaf and then wash all surfaces with short, soft strokes or a patting motion. We're going to wash down each one of the toes and then get in between the toes. And then gently we'll lift the foot with support and inspect the bottom of the foot while we wash all areas from top to bottom. And then we'll set this washcloth aside and place the foot back in the basin to rinse. We'll use the second washcloth to rinse the foot, squeezing the water to make sure that the foot has been rinsed well. I'm going to unfold the towel and lift the foot and place it on the towel to dry. We'll blot the foot dry around the ankle, the top of the foot, the heel of the foot, and then we'll lift the foot gently to dry the bottom. We'll take an edge of the towel and slide it gently in between each toe to blot to make sure no moisture remains behind. Now that the foot is dry, we'll get some lotion, warm it up in our hands, and then apply it to all areas of the foot except between the toes. So the top of the foot, the heel of the foot, and the sole of the foot, but not between the toes. And then we'll wipe off the excess lotion. The care plan has told us to replace the patient's sock. So once the lotion has been removed, I'll take the sock, make sure it's right side out, and scrunch it all the way up to the toe seam. We'll put the sock over the foot, making sure the toe seam lines up across the toes, and then we'll secure the sock over the heel, minimizing wrinkles and making sure the sock fits appropriately. And then we can gather our dirty linens and place them in the soiled linen hamper. So we'll place our soiled linens in the soiled linen hamper. Now we can clean our basin. I'll bring the basin to the sink. We will dispose of the water in the sink, rinse the basin, and then dispose of the rinsed water in the sink as well. I'm going to set the basin down, disinfect it per facility policy, and then use a paper towel to pick it up. We'll dry the inside with a paper towel. Throw that paper towel away. Dry the outside with a paper towel and throw that paper towel away. And then get one more for the drawer. After cleaning the basin, we'll use the paper towel to pick up the soap and the lotion and return the basin to storage. We're going to put our supplies away by opening the drawer with a paper towel. We're going to put the basin, soap, and lotion in the drawer, close the drawer with a paper towel, and then we'll throw the paper towels away. And then we'll remove our gloves, being careful not to contaminate our hands. So now I'm going to gather the barrier, and we'll throw this away, and I'll help you put your shoe back on. There you you go. Are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Your environment is clean. I'm going to go open the curtain and give you your call light.
Thank you.
Okay, Mr. Jones, here's your call light. If you should need anything at all, just press that red button. I'll be happy to come back and help you.
Thank you.
Is there anything else I can get for you before I wash my hands?
No, thank you.
Okay, have a great day. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. All right, any questions on that? Any questions on that? Okay, the next one that we're going to do is mouth care. This is the next skill. If you look down here, you'll see all of the principles involved. They're all spelled out for us here. We've got our skill-specific steps, and then down here it tells you how long you have to do this particular skill, which is 12 minutes. You will be doing this on another live person, testing student. That person will be positioned in bed at the beginning of the skill. Does it take you guys 12 minutes to brush your teeth? No. We're not flossing. We're not doing anything crazy. We're brushing teeth. Now we're brushing somebody else's teeth, which does make it just a little bit longer, but still 12 minutes, way, way, way more time than you need. So don't rush this one, okay? Page 93 has our step-by-step instructions, our care plan at the top of the page, and our supplies at the bottom. Let's take a look at this care plan. It says a resident with natural teeth is lying in bed and needs mouth care. The resident is not able to provide their own mouth care. That means we have to do it. It says natural teeth, so their own teeth. But some of you are going to ask, well, what if they had dentures? We have a whole skill for that coming up next week. Stay tuned. This one is for somebody with natural teeth. These are all the principles involved in this skill that we already know, so let's focus on the principles that are unique to this skill. Skill-specific steps. So the first problem is our patient is laying down, and that's a problem because this is not a safe position to do mouth care in. We need to get our patient sitting up. Okay, so that's a step, and it's an important step. It's a safety step. So if you miss this step, if you do not put the patient in an upright position, it is an automatic failure because of the results to the patient. Does that make sense? This is a critical checkpoint. But this really messes students up. I mean, in a really big way. Brushing teeth is not hard at all. Not at all, okay? But this step really seems to confuse students because of what I've already taught you. Do you remember our cardinal rule with the opening? We cannot touch the patient until our hands are clean. Okay, so keep that in mind. That's important. We can't touch the patient until our hands are clean. Well, here's the problem. When you have a pillow behind your head, when you're laying down, that pillow is comfortable. But when you're sitting up, that pillow actually pushes the head forward out of alignment with the body. It's not comfortable, and more importantly, it's not safe for mouth care. Good? Understand that? Because you're not in alignment. Okay, so we know we have to wash our hands before we touch the patient. We know that when we put the head of the bed up, we got to move that pillow, which is touching the patient. So which one of these comes first? I'm very confused, and this is where students get a little bit messed up. I'm going to tell you that for the test, they don't care. Okay? You're way more wrapped up in this than the evaluators are. But I do want to explain to you the right way of doing this, because it does matter in a clinical setting. Okay, so if you look on page 93 and you look at step 7, it tells us to do our whole opening. Good morning, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do mouth care. Is that okay? I'm going to close the curtain, wash my hands, get my supplies, get everything set up. And then I want to put the head of the bed up. But my hands are clean, and I've only touched clean supplies. Is that bed controller clean? No. So I'm going to get a paper towel between my hands and the bed controller, and that keeps them clean. Then once the patient is up, we can move that pillow down behind their back so they're sitting up and everything remains in alignment. Good? So it's the patient's own cooties, okay? Anything in the patient's environment is their own cooties. It's no different than them putting their hand under their pillow and then rubbing their eyes. Patient's own cooties. But that bed controller probably has cooties that the patient isn't limited just to the patient. Okay? Do you guys understand the difference there? Man, that weather out there is crazy. So once we get the patient sitting up, we put that pillow down behind their back, not their head. Then we're going to put a towel over their chest. And this is going to help protect their clothing from any toothpaste that might drip down. We talked about this on day 1. We're going to wet our toothbrush. We always wet a toothbrush before we put toothpaste on it. That allows the toothpaste to spread. If you put toothpaste on a dry toothbrush, it doesn't spread as effectively. It clumps up. So wet your toothbrush in the cup of water. Put the toothpaste on. Let me talk to you about toothpaste real quick. Right, this is what we have been trained to do with TV commercials, right? This big, long stripe of toothpaste. And if you read the box, it'll tell you, in most cases, to use a pea-size amount. That is not a pea-size amount. That's 2 or 3 pea-sized amounts. So why do their commercials show us this big, stripy thing, but their box says something different? Marketing. If they can get you to use more, you're going to have to buy more. And because we pay attention to what we see first, remember me saying that earlier today? Our brain is wired to pay attention to what we see first. We don't pay attention to that box. We already know how to put toothpaste on because the commercial showed us. Now, the problem with that, if you're at your house and you are brushing your teeth, your own teeth, you're standing over a sink. So all that extra toothpaste is going to go down into the sink and you really don't care because you've got money to burn. So you're going to let all that extra toothpaste go down into the sink and you'll wash it out. But when our patient is in bed and we're using that much toothpaste, it doesn't have anywhere to go. So now it's a choking hazard. But it also is going to drip out of their mouth and onto, it's going to be a drippy mess. So when you're doing this with a patient, you probably want to just use a little bit of toothpaste. It's easier for them to rinse, it's safer, and it's using the toothpaste in a manner it was designed to be used. I have no idea what's going on out there. Okay, so then we're going to brush. Now, our checkpoint is brush sides and biting surfaces of teeth and gum line with a gentle motion. It doesn't tell you you have to do the front first or last. It doesn't tell you to do the back first or last. It doesn't tell you whether to go back and forth or up and down. And most importantly, it doesn't tell you to brush for 2 minutes. There's no time here. There's no time. As long as you get the top, the bottom, the front, the back, and the tongue, you're good. There's no time involved here. Okay, good? Good. All right. Remember, the more toothpaste you use, the more they have to rinse. So we're going to use a little bit of toothpaste. We're going to brush all surfaces, and then we're going to give them a cup of water and a basin to spit in so that they can rinse their mouth and get rid of the rinse water. If you used a bunch of toothpaste, you're going to be there a while. A long while. Because they're going to have to rinse and spit a lot. So it really does benefit you to use a little bit of toothpaste. After that, you're going to dry them off with that towel. This is the #1 missed step on this skill. This is the #1 missed step on this skill. People forget to dry the patient's mouth. Imagine how uncomfortable that is to have spit dripping from your mouth and have nobody address it. That's horrible. We don't do that. All right, so this is one of the most common questions I get. Am I going to have to brush everybody's teeth? And the answer is no. If they can brush their own, they're going to brush their own. How weird would it be if I walked into your house at 6 o'clock tomorrow morning armed with a toothbrush and toothpaste and said, open wide? Right? That's kind of weird because you've been brushing your own teeth for a while now and you're not willing to give that up. This is a very personal skill. And patients aren't going to want you doing this skill if they can do it themselves. So our care plan for people who can do it themselves will say self-mouth care. We're not involved in that. But you may have patients that maybe have arthritis and they can't get the cap off of the toothpaste or they can't squeeze the toothpaste well. In that case, your care plan might say mouth care setup and cleanup. They do the brush. We're going to help them get ready for it and clean up after. We follow our care plan. Good? Good? All right. We're in good shape with timing. I'm going to go over our skill-specific steps for this, how we're going to use those steps to check off our checklist, and we're going to watch the video on how to do mouth care. Super easy. You notice today's skills are pretty easy. Pretty easy, right? The rest of today is going to be test registration instructions. So when we get to that point, once the skill is over, when we get to that point, I'm going to actually point out on the clock where we're at, and it's going to be right around 11:30. That way, when you go home and you're trying to do all the test stuff that you have to do, you will remember exactly what point to fast forward to get to test registration. Good? Good? Okay. And then if we have any time left over, which we might, 15 or 20 minutes, we'll open it up for practice. Okay. So let's use these principles to check off this checklist. We're going to follow our care plan. We're going to do our opening. We're going to wear gloves. We're in a wet body opening. We need gloves here. Need gloves, body fluids. We're going to use a barrier. We're not going to take a break, no. We're going to abide by linen rules. Remember, don't snap or shake linens. Take what you need, but use what you take. Don't put anything on the floor. All of those linen rules. We're going to clean our basin like we clean everything else. Rinse it, dry it, store it. And we're going to do our skill-specific steps. Now, this skill has a lot of skill-specific steps, but they're ones that you already know. You know how to brush teeth, people. You know how to brush teeth. And I just told you how important it is to get the patient sitting up before you brush your teeth. You know how to do this. And then you'll do your closing. This care plan is only for this patient, nobody else. This one has dentures, different care plan. This one does her own mouth care, different care plan. And that one has, we help them with mouth care, but he's ambulatory. He can get them to go to the bathroom for us to do mouth care. He's not stuck in bed. It's just this one that is stuck in bed. Everybody has a different care plan. Are you starting to really kind of put that together, that everybody's going to have a different care plan? Good. All right, Jake, mouth care, please, maestro. Good morning, Mr. Jones. How are you?
I'm well. How are you?
Fantastic. I'd like to perform mouth care on you. Is that okay?
Yes.
I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. I'm going to use a paper towel as a barrier to put the head of the bed up, since my hands are clean and the bed controller is not. Once we get the patient to an upright sitting position, I can throw the barrier away and then adjust the pillow so it's a little more behind his back rather than his head. There we go. Good?
Yes.
Okay, let me go get the rest of my supplies and I'll be right back. I'll gather my supplies. We're going to start with a barrier, and that gives us a clean place to place our clean supplies. So we're going to open the barrier up. And I also need a towel. We're going to get an emesis basin, a toothbrush, toothpaste, and a cup of water. And we also need a pair of gloves. I'm going to get my toothbrush prepared by wetting it and putting toothpaste on, and then storing it in the emesis basin until I'm ready to use it. Mr. Jones, can I place this towel over your chest?
Yes, please.
Thank you. This is just going to help keep your clothing clean. I'll put my gloves on. And now we're ready to brush your teeth. I'm going to brush the top, the bottom, the front, the back, and your tongue. So can you open wide for me? I'll start in the back, on the top, both sides. And then the bottom, both sides. The front, both top and bottom. And can you bring your teeth together? Thank you very much. And then stick your tongue out. Thank you. I'll set this aside, and now we can rinse. Go ahead and take a sip. Another sip.
Yes, please.
Okay. I'll pour the water in the emesis basin, set them on the table, and then I'll take this towel away and put it in dirty linen. I'm going to go clean my basin. We'll clean the emesis basin by dumping the saliva into the sink, rinsing the basin, setting it down, and disinfecting per facility policy. Then we'll take a paper towel to pick it up, a paper towel to dry the inside. We'll throw that paper towel away. Paper towel to dry the outside, throw that paper towel away, and one for the drawer. Now I can return the basin to storage, putting the toothpaste in the basin and using a paper towel to open the drawer to store the basin back in it. We'll close the drawer with a paper towel and then throw those paper towels away. All of these disposables will be disposed of. I'm going to go throw this away. I'll be right back.
Okay.
Now I can remove my gloves. Okay, Mr. Jones, is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes.
Okay. Bed is in the low position. Your environment is clean. Let me get your call light for you. Would you like a magazine before I go?
No, thank you.
Okay. Here's your call light. If you need anything at all, just press that red button. We'll be happy to come in and help. I'm going to go open your curtain and wash my hands. After washing my hands, I'll review the care plan, make any corrections, and then tell the evaluator my skill is done. All right, Jake just pointed out to me I forgot a whole skill today. So let's learn respirations. This is why we have him, to keep me on the straight and narrow. Let's move on to respirations. This is on page 54. This is a very quick skill. This is actually the one of the quickest skills there is on the state exam. The only one that's quicker is range of motion, elbow and wrist. So respirations, page 54, you can see the principles down the side. They're all spelled out for us here, and they're the big four. I mean, there's nothing new here. This is all stuff we've seen now about 8 times. Skill-specific steps we'll go over in a minute. Down here is your testing information. Somebody with your level of experience should be able to do this skill in 4 minutes or 5 minutes or less. So it's going to be done on a live testing student, and that person will be positioned in bed. This is a documentation skill. So we're going to have to do the skill, wash our hands, document, and wash our hands again. If you look on page 55, you can see the care plan at the top, step-by-step instructions, supplies at the bottom. This clipboard here is the actual documentation sheet that you will have on the state exam. That's what it'll look like. If you want a larger one that you can use for practice, go to page 168 in your book, and you'll see a larger version of this that you can use for practice. Here's our care plan. Patient will be lying in bed for the skill. Count the patient's respirations for 1 full minute and record your readings. How long are we counting for? 1 minute. Why? Care plan said so. Out there in the wild, you will be told, yeah, we just count for 15 seconds and multiply that by 4. And that's perfectly okay as long as your care plan does not say count for 1 full minute. But this care plan does, so that's what we'll do. We know all of these principles. We know to follow the care plan. We know how to do our opening. Hi, Ms. Jones. My name is Patty. I'm your CNA today. I'm here to take your vital signs. Is that okay? Let me close curtain, wash my hands, get my supplies. I'll be right back. I'm going to evaluate if I need gloves. I might not. Depends on what's going on with this patient. But your patient is another testing student, fully clothed, holding on to all of their body fluids. So chances are you won't. And then we're going to do the closing. Thank you so much, Ms. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Environment's clean, bed's in the low position. Here's your call light. You're covered. Open curtain. Wash hands. Document. Wash hands again. Read the care plan. Make sure I did it right. And then say, my skill is done. Super quick skill. Super quick skill. But let's learn what we need to learn about this particular skill, our skill steps. So the first thing you need to know is that we don't tell people that we're counting their respirations. Because if you tell somebody, their breathing will change. So if I say, okay, I'm going to count your breathing, ready, set, go. People either stop breathing or they start breathing fast because now I'm being watched. And that makes us anxious, nervous. So we don't tell somebody I'm counting your breathing. We just say I'm taking your vital signs. Okay? But there's another problem with this. It's one that people don't really think about too much. I want you to imagine that you are the mannequin laying here, okay? You're the mannequin. I'm going to take your vital signs. Is that okay? All right. Ready? Go. How weird is that? I am staring at a stranger's chest, not touching them, not talking to them. It is creepy for your patients. Now, what do you think that's going to do to their anxiety? Yeah, and what do you think anxiety does to respiration rates? Speeds it up, makes it faster. So if we do this, we're not going to get an accurate reading. So how do we get around it? Well, for this skill, I want her to think that I'm taking her pulse. If I can make her think I'm taking her pulse, then her attention is here, not here. So when I do this skill, I'm going to do my opening, all the things, and then I'm going to take her wrist, keeping the elbow supported on the bed, and I'm going to put my hands around her wrist. I'm not taking her pulse. I do not have the pulse. I am literally holding her hand, but she doesn't know that. Okay, I'm just putting my hands here, and now I can count her breathing without her being fixated on what I'm counting. She's fixated here, not here. I'll get a much more accurate reading. So when you see this skill, it's going to look like we're taking the pulse, but we're not. We're counting the breathing. Make sense? Okay, and that's why we say vital signs, because pulse, respiration, blood pressure, temperature, those are all vital signs. We're being a little vague here. All right, in and out counts as one cycle. So that was one breath. Another breath. It doesn't matter where you count in that cycle, it all counts as one. The whole thing, in and out, counts as one. Okay, good? Good. Okay, we're going to count for 1 full minute because that's what our care plan tells us to do. Remember that you can count for 15 seconds and multiply by 4 if your care plan does not specify. We've already talked about that with pulse. Normal respirations are between 12 and 20. That's what we're hoping for, somewhere in there. If we got 10, what would we do with that information? If we got 28, what would we do? Okay, so 12 to 20 is normal. Now, that's 8 breaths, right? 12 to 20, that's 8 breaths, right? That's normal, 12 to 20. Not a huge range. Okay, now how far can you be off for this skill? You can be off by 4 breaths in either direction. Or I'm sorry, 2 breaths in either direction, which is 4. So let's say that you got 16. And the evaluator, if they got 14, 15, 16, 17, or 18, you're still considered accurate. It's half of the whole range, guys. This skill isn't about accuracy. The skill isn't about accuracy. It's about following the care plan. That's what they're grading you on here. Did you count for 1 full minute? Do you understand the importance here? That's what they're grading you on. Good? Now, for the exam, the evaluators are also going to count when you count. So you actually have to look at the clock and say start out loud. So they know when to start counting respirations. And you're going to say stop at the end of your counting so they can stop counting. That way they know how long you counted, but also they're going to get the same number that you do.
I'm just a little bit confused on the 15 times 4. How do you
Okay.
use that? Or like, actually, I just responded my own question, but like how do you use that? Or like, how does that affect the, if that makes sense?
Okay. So for pulse or respirations, either way, if your care plan doesn't tell you how to do it, whether to count for 1 full minute, use a pulse ox, that type of thing, if there are no instructions for you, you can count whatever it is we're counting, whether it's pulse or respirations, for 15 seconds. Now, we know everything is always reported over 1 minute. Okay, so we need that 1 minute count. So how could we get a 1 minute count by just counting for a portion of that minute? So let's say that we count for 15 seconds. We count respirations, and I get 4. This person breathed 4 times in and out in this period. Well, if it's regular, then he would have also breathed 4 times in this 15 seconds, and another 4 times in this 15 seconds, and another 4 times in this 15 seconds, because he breathes regularly. So if I took that 4 and I did it 4 times, it's this count times 1, 1, 2, 3, 4. So 15 seconds multiplied by 4. So what's 4 times 4? 16. So this patient breathed 16 times a minute. I would get the same number if I counted for that whole minute because it's regular. Now, when we use that full minute count, when we tell you, hey, I want you to count for a full minute, it's because our breathing is not regular or our pulse is not regular. There's something that has affected it. And if you have an irregular respiration, then this one's going to be different because it's irregular. And this one's going to be different because it's irregular. So we have to count for that whole minute. Does that help? Yeah. So how would I know which one to use? Well, if the care plan tells me to count for 1 full minute, then I have to count for 1 full minute. Okay? All right, so we're going to say start out loud when we start. We're going to say stop out loud when we stop so the evaluator can keep up. And then we're going to do our closing and document our reading. Remember, we have to end skill with clean hands. You guys remember that? All right, I have a whole lesson on documentation on page 48 that you probably want to read sometime this weekend. But the big thing about documentation is that in a lot of settings, CNAs are not allowed to document in words. You're not allowed to document in words. Numbers, yes. Words, no. Now, this varies by facility. The facility gets to set the rules here. So your facility may allow CNAs to document, possibly. But as a general rule, we don't. If you are allowed to document in words, there's got to be some rules involved. Number 1, you have to be accurate. You need to keep it brief, but it does need to be complete. We call it the ABCs of documentation: accurate, brief, and complete. Only document what you did. If a shift going off and you're coming on, if they say, hey, I forgot to document that this patient had a bowel movement, can you put it in the book for me? Your answer is no. I cannot document for another person. That's a legal principle. They have to go document that themselves. You are not allowed to document for somebody else. If they did it, if they saw it, they document it. Good? CNA just got in trouble for this, I think it was like last year or something. A nurse was diverting narcotics and telling the CNA to document that the patient dropped the pills on the floor. That, the CNA went in the room and saw pills on the floor. And the CNA did it because the nurse asked her to. So she got in a lot of trouble because we don't document what we did not do. In this case, she didn't see that. Good? Make sense? So documentation principles, super important. You probably want to read this over the weekend. All right, so now we know all the steps. Let's apply them to this particular checklist. We're going to follow our care plan. We're going to do our opening. We're going to evaluate if we need gloves. We're going to do our skill-specific steps, which is one. There's one. And we're going to do our closing. So this is not a hard skill, guys, but I do want to show you a cheat. I like cheats, and I like them even more when they're legal. So when you are counting somebody's respirations and they're laying down, makes it way easier to count because they're laying down. You're going to actually watch the upper tummy area right here go up and down as they're breathing. It's kind of hard to see, though. It's kind of hard to see. If you put an alcohol pad, I know I've got one in here, there we go. If you put an alcohol pad there before you start counting, it will actually amplify your ability to see the respirations because our eye is drawn to movement when it's a contrasting color. So it's psychology. I didn't change this patient's breathing at all. I changed your ability to see it through psychology. So if I put an alcohol pad on their tummy, it actually makes the movement of the tummy much easier to see and count. Now remember, for the exam, you've got 2 evaluators that have to count with you. You want them against the wall. You do not want them hanging out over your shoulders. You want them as far away from you during the test as you can get them. If you put an alcohol pad on their tummy, they'll be able to see it from over there. They won't have to be close. That's a win-win for you. So you're allowed to use this for the test. You can use it in a clinical setting. After a while, once you've kind of got your feet wet as a CNA, you won't need this anymore. You'll be able to pick up on the movements pretty easily. But when you're first learning, these are training wheels and they're allowed to be used, no problem. Now at the end of the skill, you just throw this away. It's disposable. Why do we use alcohol pads though? Because if you use anything else, your patient's going to ask about it. Patients expect alcohol pads to be used in clinical settings. They rarely ask. They just assume you need it for something medical later. If they do ask, all you have to do is say, I need that for something later. And they'll say, okay, because they're familiar with them. If you put anything else on their tummy, they're going to go, what's going on? Why are you putting that there? What are you doing? They're going to have a million questions, and you're probably going to make them very nervous. Alcohol pads allow us to get away with that. Good? Good. All right, let's go ahead and watch this video now. Just like with Pulse, you guys remember learning Pulse? Just like with Pulse, on the bottom of the screen with Pulse, I had the words that went big and small for you to count with. I do the same thing here, right? So I show you in and out, how they're breathing. Count along. Remember, in and out is 1. That whole thing is 1. Good? So count along, see if you can get the same answer that I get.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I need to get your vital signs. Is that okay?
Yes.
I'm going to close your curtain. Let me go wash my hands, and I'll be right back. Okay, Mr. Jones, I'm just going to lay this on your stomach for later. I'm going to elevate your forearm, keeping your elbow on the bed. And this will take me about a minute. I'll need you to remain quiet during that time, but I'll let you know as soon as I'm done, okay? And we're going to start. Ready, set, start. Stop. Thank you very much, Mr. Jones. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes, ma'am.
Would you like a magazine before I go?
No, thank you.
Okay, bed's in the low position. The environment is clean. Here's your call light. If
Thank
you need anything at all, just press that red button. We'll be happy to help you.
Thank you.
I'm going to go ahead and open the curtain and throw my alcohol pad away and wash my hands. After washing my hands, I'm going to document on the sheet provided by the evaluator and then wash my hands again. After washing my hands a final time, I'm going to review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. So if you got 10, 11, 12, 13, or 14, you are considered accurate. So if you got any of those numbers, you're good. Everybody get one of those numbers? Okay. Do you see how much easier it is to see the respirations with the alcohol pad on the tummy? Yeah, that's allowed. You can use it. Okay. Any questions on that one?
I have a question. When you picked up the patient's hand,
Mm-hmm.
you said you want vital signs. You don't tell them to breathe normal?
No, you do not want to give them any instructions on breathing at all. And that's actually a checkpoint. Do not instruct patient on how to breathe. Yep. Because as soon as you say, okay, breathe normal, you know what they're not going to do? Breathe normal. So I'm going to ask you, and let me demonstrate it real quick. I'm going to ask you, okay, go ahead and breathe normal. Ready? Go. You just held your breath. Because now you're thinking about it. Now you're trying to breathe normal, but it affects your breathing rate. Because you're like, okay, when do I start? So it's important not to give them instructions. We want what we call baseline. Okay? All right, good? Ready to move on? Okay, at 11:50 is when we're going to start. So remember that number, or 10 till 12, is when we're going to start working on the test registration instructions. So if you have to review this, now you know where it's at, okay? On my main website, so this is foryourcna.com, under the main website, I have the main website divided up into segments. We have training, which is where you are right now. We have testing, which is coming up for you. And then we have after certification, right? So what we're about to do is test registration instructions, which would be under testing. So if you go to my main website, under the testing tab, you'll see test registration instructions. And when you click on that, it's going to bring up a page that has all of the information about how to register for the test. So I'm going to go through this step by step with you, and I'm going to give you some stuff that's not on that website. Okay, not yet. And that's why I want you to know where to find this lecture, because you may have to go back and review it. Good? Good? Okay. So let's take a look at this flyer that was handed out. So this is one side, this is the other. So try to find this flyer. It's on this is the back, this is the front. Find this flyer. Has 1, 2, 3, 4. These are the steps of test registration. Registering for the CNA test is way more complex than just sending them your name, email, and phone number. This is a very complex process, so we have to walk through it. So the first thing you have to do is obtain a background check. That's step number 1. And I know some of you are going to argue with me and say, but I've already got one. And I'm going to answer that argument in a minute. Please know step number 1 is get a background check. Now, how do we do that? If you flip it over, I have instructions on how to get your background check through a specific company. You can go anywhere you want to. I have no affiliation with this company at all. But I will tell you that the students that use this get tested way quicker. There's no problems. If you go to the sheriff's department to try to get your background check, it can delay you months. Okay? I know this one works, but you can go wherever you want. These are the instructions you need to use. But I want to bring your attention to the third one down. Do you see this one right here? Okay, it says use code EDOH 03810. You guys see that? Or 0380? Those are zeros. So EDOH letter 0380. The O is an O, a letter, 0380Z. So I want to bring that to your attention because that got a little confusing for my last group. Good? Okay, so once we do our background check, we'll talk about that a little bit more in a minute. Once we do the background check, then we can complete our test registration. After we do the test registration, we have to wait to get approved. And then once we get approved, then we get our test date. Good? We're going to talk about this process in detail in a few minutes. This is an overview. All right, so background check. A lot of people will tell me, I've already got a background check. I worked in banking, I worked with kids, I work in healthcare, whatever the case may be. This is from the Board of Nursing, who is going to approve you for testing. In 2 places in their frequently asked questions, they address this very topic. If a background check is complete at the time of entry, must it be completed again for application on the CNA exam? They answer this, yes, a new background check is required on all new applications for the CNA exam. They repeat that here, saying, I've got a background check. Do I still have to go get one? Yes. A new background check is required at the time of application. So those of you who are already working in healthcare, I know you've already done a background check. That does not work for this. Not according to the Board of Nursing. Everybody with me? Now, I'm making a big deal out of this because I've had several students lately that did not do their background check first and they are still waiting to test. It has to be done in order, guys. Has to be done in order. On the other hand, I do have a couple people who do work in healthcare who took my last class and did not do a background check and still got their test date. So all I can tell you is what the Board of Nursing says. You might get lucky if you try it. Or it could delay you for several months. All right. So these are the instructions on how to do the background check. Just go to the website indicated and follow those instructions. It'll get you where you need to go. Good? So let me explain to you the process. Because I find it's, for my brain anyway, it's helpful for me to understand how the whole process works. So I understand where I am in the process. So when you get your background check, that background check goes to the clearinghouse. That's what it's called, the clearinghouse. They don't give you anything. They don't give you a card. They don't give you anything to mail in. They don't give you anything. You don't need anything. You go to your appointment. They take a picture. They take fingerprints. You sign, and that's it. That's all you have to do. You're not going to send anything anywhere. The company sends it. They send it to the clearinghouse. Then you apply for the test. Good? Background, application. Because what happens is when you apply, the Prometric, who is the testing agency, goes and gets that background check. They contact the clearinghouse, not you. This is called chain of custody because everybody has a cell phone in your pocket. That cell phone is capable of taking a bad background check and making it into a good background check with a couple of edits. You can't have access to your background check. Chain of custody. Good? Make sense? So you get your background check done, you apply with Prometric. Prometric goes and gets that background check and puts it with your application. They take your payment. Now, as long as your payment goes through and they found your background check, they put those things with your application and they make a packet. That packet is then sent to the Board of Nursing. The Board of Nursing has a human. This is not automated. A human has to look at all of this and clear you for testing. A human. That way there are no administrative errors here. Okay? But that also means because it's a human, it can take a couple of days to get this done. Good? Make sense? Got it? Okay. All right, so we did our background check, and now we have to do our test registration, which we're going to do together in class. And that's what we just passed out to you. So the paperwork that I just passed out to you, this paperwork, this packet, I'm going to show you where I got it, just in case this one gets wet, your dog eats it, whatever the case may be, okay? If you go to prometric.com/exams/nurse-a-fl, that's where you're going to go for all things Prometric. Good? Okay, when you go to this website, this is what comes up. It doesn't look like a whole lot. You have to open up each one of these accordions to get more information inside each one. When you look at the page, it's like there's nothing here. You actually have to click the plus to open this up. So when you click the plus for application process, this is what comes up. There's an online application form. We'll talk about that in a minute. And there's a paper application. The paper application is the one you have in front of you. This is Prometric's paper application. Okay? Now, online, way quicker, guys. Way quicker. If you fill this out in class like we're going to do together, and you pop this into the mail, it's going to take 1 to 2 weeks longer to process your application. Now, the online application, exactly the same, looks exactly the same. So you can use this that we fill out together and put the information into the online and make your process go a little quicker. There are 3 significant differences between the paper and online that we'll talk about as we go. Okay, good? Good? So in class, I suggest you fill this out with me to use as a template to fill out the online. All right, so this is our paper application. The first thing that you're going to see right here is a stop sign, and it says stop. You need 2 forms of ID, and they both have to have the same name. The same name. One of them must be a photo ID, a non-expired photo ID. So we had a student back at the beginning of the year. She went to her test, did not realize that her driver's license had expired on her birthday like a week before, and they would not let her test. It has to be a non-expired photo ID. Good? Okay. You also have to have one with a signature. This can be a debit card, it can be a credit card, it can be a library card, it can be a Social Security card, just something with a signature, and the names have to match. Once you have 2 forms of ID, you're good to go. The next section is ADA accommodations. So if you need a seeing eye dog or a sign language interpreter or something like that, fill this out. There's a whole packet. You have to take it to your doctor to get filled out. It's a whole big thing. But if you need that, check yes, fill out the packet, take care of it. Going down here to our demographic details. The very first question here says, have you taken the CNA written or clinical skills test before since 2002 in Florida. Now, 2002 is when we actually started keeping track of CNAs and issuing CNA numbers. So what it's asking is, do you have a CNA number with us? Because that number is yours throughout your entire life. That is your number. Nobody else has that number. So we're asking, should we go in the archives and find it? That's what that question is. Okay, good. Down below is asking your name. You can fill that out on your own. We're not going to do the demographic in class today. You can do that part on your own. If you go to your next page, page 2, which will be on the back, the rest of your demographic information is there. Now let's go down here to gender. Please indicate the gender you were born with. So indicate the gender you were born with. They're making a big deal out of that now. And indicate whether you have a high school diploma or not. Now, if you're 18 or older, that's just information. If you're under 18, you must have a high school diploma or GED to test, but only if you're under 18. If you're 18 or older, there's no requirements to test. Now let's go down to this section. This is where you need my help. This is where you're going to need my help. It's criminal and Medicare, Medicaid fraud questions. If you have a felony in your background, see me after class. If you have no felonies in your background, for number 1, check no and skip A, B, C, D, E. Don't put anything there. Just put a no for number 1. Go down to number 2. If you have no felonies in your background, check no for number 2 and turn the page. Okay. Now, 3, 4, and 5 don't have to do with felonies. Okay, 1 and 2 had to do with felonies. 3, 4, and 5 don't. But let me explain to you what 3, 4, and 5 is. If you worked for a provider that was part of a Medicare or Medicaid fraud case. So if the doctor, you worked for a doctor, the doctor defrauded Medicare through false billing, they were caught, they went to court, you would also have gone to court because they want to find out how much you know and how involved you were in this fraud. Good? If it was severe enough, they would tell you you cannot work in healthcare ever again because you have the ability to defraud the government. We can't let you around billing information. Do you guys understand why this is a big deal? So, if that situation applied to you, you need to answer 3, 4, and 5. If that situation has never applied to you, you did not go to court, you did not work for a provider that got caught with Medicare or Medicaid billing, 3, 4, and 5 are no. This is not hidden. This is you are involved in this court case. Okay, this would not be a surprise to you if it applies. If you have no idea what I'm talking about, your answer is no. Okay. This is important because we actually have 2 doctors in our community that were caught with this recently. 2 doctors in our community were caught recently. Big money. Big money. Crazy. All right, let's go down to the next section, disciplinary history. If you were a CNA or medical professional and you had disciplinary action taken against your license, if you've never been a medical Okay, try that. Testing. 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 If so if you were an occupational therapist, you were in Indiana, you hit an old person, and they took administrative action against your certification, that's what we would want to know. Okay. If you've never been a medical professional, those will all be no. Let's go down to criminal history. You would think this is the easiest part of the test. It's probably not. It's asking very clearly, do you have a criminal history, yes or no? If the answer is, well, maybe, then it's probably yes. The next question asks if you've ever had any records sealed. This is also called expunged. If you paid a lawyer money to make a criminal history go away, we're still going to find it. They lied, they took your money. We're still going to find it. And then the last question there is, do you have a juvie record? Everybody was young and dumb. Not everybody got caught. Everybody made some bad decisions when they were young. Now, a question I get asked a lot is, what if I have a criminal history? Is that going to keep me from testing? And the answer is maybe not, probably not. They look at several things. The first thing they look at is the severity of the charge. Okay, how serious was it? The second thing they look at is how many charges are there. And then they're going to look at how long ago that charge was. Then they look at things like, did you do what you were supposed to do? Did you pay your fines, do your community service, attend whatever classes you needed to attend, and have you been cleaned since? They look at all of that, and that's why it's a person reviewing your application, not a computer. If they have a question, so one DUI, 18 years ago, you were young and dumb, but you learned your lesson and you've been clean since. 16 DUIs, and the last one was last month, shows a pattern. See how those are two different things? Those are the things that they look at. Okay, so turn the page, and we're going to go to page 4. I cannot help you on page 4. You're on your own. Read the security number in at the bottom, but we're not going to do that in class, so we're going to go to page 5.
It's cutting in and out. I think it's either getting a bad signal or that cable is loose.
I think I'm pretty in trouble. Okay, let me see.
There we go.
Is it receiving now?
So
Okay.
it's receiving the signal.
All right. So we won't use, it's the mic that's going bad. I'll just use the unit itself. Let me put this up here so maybe it'll pick up a little better. Okay, so at the top of page 5, one more time, you will see that I've already checked off E3 Challenger for you. I've already checked that off. Do not select anything else. I know you're sitting in a classroom where you're not a state-approved 120-hour program with clinicals. So E1, E2 does not apply to us. We are E3 Challenger. But you're in good company because over 80% of all testers in Florida are challengers. This is the most common way people take the exam. Okay? So I've also X'd out the next section, training information, because it tells us if you chose E1 or E2 to fill that out. We didn't. We chose E3. So we don't need to provide any training information. Good? All right, so now let's go down to test site. All of us are going to be testing in a regional test site. A regional test site. So in the back of your packet, the very last page, you will see a listing front and back of all of the testing centers in Florida. Now, Prometric also provides this on their website. It'll give you a link to test center list, and this is what you'll see when you print it out. These are not arranged in any order. So trying to find one in your area is really hard. So what I did is I took this and I put it into regions for you. Now down here at the bottom, you'll see one, the one up from the very last one with a star on it. That is our closest testing center. Okay, the one with the star, on the bottom of the first page. That is our closest testing center, but there are 2 other testing centers in Tampa. One is over by Busch Gardens, and one is over like Temple Terrace area. So there are a couple that you have to choose from. If I have anyone from Citrus County, there is one in Ocala that you'll see on there that might be closer to you. So you'll want to, basically plan out which testing center you want to go to. Now on that list, you'll also see a code. So our closest one is CNA TAMAIR. If you're going to send in your paper application, you want to write that code in here. Because what you're telling Prometric is, I want to take the test and I want to take it here. There's testing centers all over Florida. You don't want them to schedule you in Tallahassee or Miami or Jacksonville. We want to tell them this is where I want to go to test. So you write your test code here. Now, I told you there's 3 differences between the paper application and the online application. This is one of them. In the online application, there's going to be a drop-down menu that lists the names of all of the testing centers. So you're going to want to pay attention to the name on this list that I gave you and look for that. Good? Good? All right. Now, once we have told them that we're challenging, we're not going to provide training center information, we want to test here, we have to tell them which test we want to take. And there are some options here. Do I have anyone who Spanish is your first language, your initial language? Okay, do you want to test the written test in Spanish or English? Okay, that's most people, yeah, if I'm learning in English, testing in English is easier. So for all of you guys, we're going to test in English for the written. So we have 2 options here. The first one is the option 99% of people check. It's a plain Jane test. Clinical skills and written in English. There we go. But if you want the computer to read the question to you, if you have ADHD, if you have dyslexia, learning disabilities, anything like that, and you want the computer to read the written test questions and answer choices to you, then you would check the second option. So if English is not your first language, you might be better with verbal rather than written. I don't know. In that case, the second option would be good for you. There's no extra cost. Anybody can choose the second option, but you want to choose one of those two. Now, if for some reason you fail one part of the test, let's say you passed the written but you failed the skills, you only have to retake the part that you failed. Whatever you passed stands for 2 years. It's good for 2 years. So you would want to retest skills. That's what's down here. Or if you pass the skills and failed the written, you would want to retest written, and that's here. So this section is for initial testing and retesting. We're just focused on initial testing. Now, in the online, it's going to ask you, are you testing for the first time or are you retesting? And it'll only show you the options that are relevant to that choice. Good? Okay, let's go to the next page. So remember, these sections are for retesting. The fee is $155. That's what we have to pay when we register. And if we go to page 6, you're going to see an affidavit here that says that we have received 2 forms. Those 2 forms are right here in your packet. It's the FDLE and the FBI notification of how they're going to use your information to allow you to test. Okay, it's their privacy policy. We're going to check that yes box says yes, we have received a copy of that. It's up to you whether you want to read it or not, but you've got one. Down here is an attestation. You need to read, sign, and date. Do that on your own. Let's go down to the very bottom here. This, right here, this. Very bottom of page 6. This is probably the most important part of this application. It very clearly tells us that if we did not receive our authorization to test within 10 to 14 business days, that's 3 weeks, people. 10 to 14 business days is 3 weeks, 3 calendar weeks. If you don't have, when you send in your application, if you don't have a test date within 3 weeks, what does it tell you to do? Yeah, contact Prometric. Does it give you a phone number? No. Call us. We're not going to tell you how. So it has a physical address at the very top up here, but I want you to go to the back of that page that you're on. Just turn. I'm sorry, then the next page, sorry. The next page. Down here, in big, bold letters, I have the phone number for Prometric for you. They don't put it on their application. This is my page. I'm giving it to you. Okay, good. Let me explain to you something about Prometric. And I hate to say this, I really do. Prometric is not the easiest company to work with. When you call Prometric, the person that's answering the phone is a minimum wage employee, and their whole job is to get you off the phone. They are not there to answer your questions. They do not know anything about your situation. And you have to understand that Prometric doesn't just do CNA training. They do, or I'm sorry, CNA testing. They do testing for real estate, for construction, for business, for IT, for coding, for daycare. I mean, they do testing for almost every industry. So when you call them up, they have no idea that you are taking a CNA exam. And they're going to give you a stock answer that has nothing to do with you. They'll say it can take up to 6 months to clear you for testing. Hold up. What does their application say? Yeah, 10 to 14 business days, which is 3 weeks. You are going to tell them that. Prometric's application with me says 10 to 14 business days, I want a supervisor. Because a supervisor can try to figure out what's happening with your specific case. But that first person you talk to on the phone, their job is to get you off the phone by telling you something that is absolutely untrue. This is CNA is one of the very few exams that requires a clinical component, which is way different than a paper and pen exam. So we follow a totally different track, but the person answering the phone doesn't know that. Good? Make sense? Okay. We had one student in the last class that is struggling with this. She still is struggling with Prometric. So call, be persistent, and get a supervisor, because the person that answers the phone is not going to help you. All right. They do give you their phone number on their website, right here, but it's in small letters. It also tells you on their website if it has been more than 5 business days since you submitted an application and you haven't gotten nothing from us, you probably ought to call. Okay, so 5 business days, if you don't get anything, you need to call. 3 weeks, if you don't get your test date, you need to call. So those are the 2 time frames that we're looking at. Good? Good. Okay. In this packet, the next page that you have is the payment page. This page right here. This is your payment page. On the back of it is my page that I gave you. This is telling you, this page is telling you what to expect on your timeline, what's going to happen. I also have it as a handout, but you're likely to lose this. So I put it here in your application packet so you'll be able to find it. Okay. Good? Questions so far?
So can we send them this particular packet?
You can mail in this packet, but remember, mailing takes longer.
Yeah.
If you take this information and put it in the online, it goes way quicker. So there's 3 areas where the online is different than the paper. Okay, one of them we've talked about. This the drop-down box. You're going to select where you want to test. That's one area that is different. But this is the drop-down that you'll see. Notice it doesn't have any addresses. It just has the name and the city. It doesn't really help you. That's why I gave you all of the testing centers with addresses so you can type it into Google Maps or whatever you want. That's one of the differences. The other is at the end of the application. You're going to have a payment portal like this. So if you're registering online, we have to pay by debit or credit card. So we have this payment portal. At the very bottom of this payment portal is a little teeny tiny box. It says, I authorize. You have to click that box. If you don't click that box, your application stops. And it doesn't give you like an error message or anything. It just doesn't get submitted. You will be sitting around waiting for 3 weeks for your test date, and you're not going to get anything because it never submitted. So pay attention to this little box. Super important. Okay. Then at the very end of the application, you have this. And it has save, submit, and cancel. We'll talk about these 3 buttons in a minute, but let's look at this first. This is what they call a required field. So our application can't be submitted unless we check one of these 2 things. It doesn't matter which box you check. I don't care. Check one. But what it's asking is, if you have a criminal history and we want more information from you about this criminal history, we're going to contact you and ask you to send us some stuff. How are you going to send us stuff? Are you sending it by fax or by mail? That's what they want to know here. If we ask you for more information, how are you planning on sending it? I don't care which one you choose. Just choose one. you're able to change later. It's fine, but choose one. Because if you don't check a box here, it's not going to submit your application and there's no error message. You'll be sitting back thinking, I registered, I'm good. And it didn't go. Okay, now the worst part of this online registration, the very worst part are these buttons. If you click save, it saves everything in your application except for that payment information and this box. So if you click save, everything stays on your screen. If then you click submit, it's going to submit your application without payment information and without this checked. And your application dies. Okay? So if you hit save, you better go up and fill out your your payment and check this box and then hit submit. Guys, if you just hit submit, it submits and saves at the same time. So don't just hit save, just go straight for submit. Okay? Good? Good. I know it's a big application. There's a lot of parts to this. I know. All right. So if you select save, it's not going to save your payment information and it has to be re-entered. So we did our background check. We completed our test registration, and now we're going to wait. So we get this attachment in our email. This is called your status report. You're going to get this attachment in your email. So I'm going to teach you how to read this attachment. So when you're looking at this, I've got 3 things circled. The first one is in blue. You have to make sure that that box says complete. If it says incomplete, they did not find your background check or your payment didn't go through. There's a problem. So if it says incomplete, you need to call them and ask for a supervisor. Now, toward the bottom, we have a purple. You guys see that purple? The purple is pending approval, and that's exactly what you want it to say. What this is telling you is they got your application, they processed it, your payment went through, thank you very much. We pulled your background check, and we sent the whole packet to the Board of Nursing, and that's where it's at right now. You are pending approval. We're waiting to hear back from the Board of Nursing. Now, once they hear back from the Board of Nursing, then they're going to send you another one of these. And then the black circled area is going to say, the purple area will change to approved. Okay. So complete, we want to look for. Purple should be pending approval and then approved. But let me point you to that black box or that black circle. That black circle is something is going to be in there if your fingerprints did not come through. So sometimes the fingerprints will come through, but they're smudged. They can't see them. So it may say complete, but if there's anything in that FBI background box, that means you have to call and find out what your next step is, what you need to do. It should be blank. Okay, it should be blank. But if it's not, then you may have to do something. You may have to go redo your fingerprints or something. Okay? All right, and then, so Board of Nursing reviews our packet. It approves us for testing and tells Prometric, hey, this person can test. We get one of these that says approved. We don't have a test date yet, though. It just says we're approved. Now, Prometric sends you that letter, says, hey, you're approved, and then it works with the testing center to find a date to put you in. You don't get to choose your date. They select one for you. They test 7 days a week. They only take off major holidays. So you might be testing on a Sunday. It's a possibility. But they set up a testing date for you. When they set up that testing date, then they send you a form that has your test date and location on it. It won't be this form. It's a different form. But it'll say you are scheduled to test for CNA written, CNA skills at this testing center on this date. And then it'll give you directions on how to get to that center.
How long do they usually take to get it scheduled?
Usually, generally speaking, okay, if you have no criminal background, and there's a lot of variables here, but if you have a clean criminal background from the time that you register until you get your test date is usually 3 weeks, which is why we do this on this day. Because if you go home this weekend and you get your background check done and you register for the test, you should be testing 1 to 2 weeks after graduation. Perfect timing.
That's what I was asking, like, how long after?
Yep.
Yeah, how
We
long it
want
takes
1 to
get
2 weeks.
Okay.
Long enough that you've had time to practice,
Yep.
short enough that you didn't forget what I said.
Right.
So that's what we're hoping for, 1 to 2 weeks, which is why we really recommend that you do your application this weekend. Now, I know some of you can't. You have to wait for paychecks, or you have vacations, or school's starting, or whatever. But you want to try to get it in as quickly as possible so we don't forget everything that we've learned while we're waiting to test. Okay, good? Now, from the time that you get your test date until you test is only about a week. They don't give you a whole lot of time. So what happens if you you've got a kindergartner this year going into kindergarten, brand new, right? And they have you testing on the first day of school. Oh, that's a horrible thing, right? Every mom should be able to cry at the door when her kindergartner goes to kindergarten, right? So you would call them up and you would say, that date doesn't work for me. You don't have to tell them why. That date doesn't work for me. If they ask why, you say, that date doesn't work for me. Don't give them any more information than they need. And they will, while you're on the phone with them, work out a mutually agreeable date for you to test. So you don't get to choose your first date, but you do have input if you do need to reschedule. Good? Good. All right. So once you get your test date, you're going to go to the testing center. You need to be there by 8:30 in the morning. Don't be late. And remember, you can't take any study material into the center, but you can leave it in your car to study in between while you're waiting. Good? That's the whole test registration process. And boy, it took us almost an hour to go through. Okay, so your homework tonight is going to be chapters 5 and 6. 5 is on dementia. Pay attention to that chapter. You'll have a lot of dementia patients in your career, and understanding how to work with them is pretty important. We'll talk about it in class on Monday as well. Chapter 6 is a skills chapter. We learn skills in class. There will be discrepancies between the step-by-step instructions in your homework book and what I teach you. Always go by what I teach you. Okay? Read the paragraphs in between. I'll do the skills. All right, you get wrap-up emails. Make sure that you pay attention to them. The link for today's class will be in that wrap-up email for you, so you can review. And then Jake's going to hand out your review sheets. And then after that, I'm going to sign, or while he does that, I'm going to sign off of online, and the rest of the class will be practice. You're free to practice if you want. You can also, it's adult education. I can't make you stay. So if you need to leave, you're free to do so as well.
I don't think I received the wrap-up emails.
Let Jake know after class, and we'll make sure that we don't have any typos. Check your promotions and your spam folders, though. All right, those of you who joined us, thank you so much for tuning in. We will see you on Monday for Class 5. Our class is half over now. So exciting. And make sure you check out the replay of the game show yesterday if you missed it. Some great questions on there that might help you on the written exam. Until next time, happy caregiving. Bye.